Thank you everyone for joining us for the webinar Lung Cancer, Controversies to Consensus. It gives me great pleasure to introduce our organizing committee. Our organizing chairman is Dr. Animesh Saha, who's a consultant clinical oncologist at Apollo Multi-Speciality Hospital, Kolkata. Our organizing secretary is Dr. Pradeep Kumar Mondal, consultant medical oncologist at Medicas Super Speciality Hospital, Kolkata. Our scientific advisor is Dr. Raja Dhar, who's a consultant pulmonologist and director and head of department at CK Birla Group of Hospitals, Kolkata. With that, it gives me great pleasure to introduce our chairperson, Dr. Puresh M. Parikh, precision and medical oncologist at Mumbai, and also the previous head of department, Department of Medical Oncology at TMH Mumbai. Welcome, sir, and I request you to give the welcome and introduction. Over to you, sir.
Thank you very much. I must thank and congratulate Dr. Animesh Saha and Dr. Mondal for organizing this very important seminar on lung cancer, aptly titled Controversies to Consensus. It also gives me the pleasure to virtually meet Dr. Raja Dhar, a dear friend of mine, whom we have interacted for many years. And I always respect the way that he concisely and precisely makes his comments, which are very pertinent. Now, as far as lung cancer is concerned, when I was a student, the third edition of DeVita's textbook, the controversy was whether a metastatic lung cancer patient deserves to be treated or not in the first line. Today, we are talking about a 20% 5-year survival with treatment. And this is purely because the consensus has been reached on how to treat this patient. And we are talking about 4th and 5th line of treatment. Patients are surviving more so that we now have to focus on how to treat brain metastasis, which is a common occurrence rather than a rare instance. So also for surgical aspects of lung cancer, the discussion is on about what is the adjuvant therapy that is appropriate for patients with stage 3A, potentially curable, operable lung cancer. And so also there are controversies in radiation oncology, which have changed based on the availability of proton therapy, for instance. On top of that, we have the availability of NGS and molecular testing. And there is increasing relevance of appropriate use of peripheral liquid biopsy, as we call it. So I think this is the reason why controversies are slowly moving into consensus. And with each step, the outcome and the survival in the patient is improved. So therefore, I think to have such a controversies to consensus seminar focused on lung cancer is going to be critically important for the participants. And I once more congratulate Animesh, Mondal, and Raja Dhar for making this possible. With these comments, I stop and hand it over back to the organizers.
Thank you so much, sir. I now request our organizing chairperson to please introduce our first speaker.
So, good evening, everyone, and good afternoon to my friend from Jordan, and good morning to my colleagues from UK. So, a warm welcome to this today's CME, Lung Cancer from Controversies to Consensus. I am Dr. Animesh Saha, I'm a clinical oncologist working in Apollo, Kolkata. So, we know according to Globocon data 2020, lung cancer is the second most common cancer with an incidence of 11.4%, just after breast cancer, and with a mortality of 18%, which is the commonest cause of cancer-related death. In 2020, there are about 2.2 million new lung cancer cases worldwide, with 1.8 million deaths. So on the contrary, it is a cancer where we have seen tremendous improvement in treatment and outcomes over the last decade or so, whether it's a systemic treatment, novel agent, immunotherapy, or modern radiotherapy. Obviously, there are controversial issues, and we are here today with all our colleagues from all over India and UK who are going to join hands together and try to sort out the controversies and try to come to a consensus. On behalf of the organizing team, I am glad to thank all the faculties, all the support scientific advisor, the delegates, the organizing team of Kavina Creation, and our sponsors, Dr. Reddy's Lab, Roche, and Cipla, for sponsoring the event. So without wasting any further time, let us crack on with our first session. Our first speaker for the webinar is Dr. Rajathar. Rajathar is a consultant pulmonologist and director and head of Department of Pulmonology, TK Birla Group of Hospital. He is a director of Training and Education Initiative of Indian Chest Society. He is also the director of Training Research, National Allergy and Asthma Bronchitis Institute, Kolkata. Thank you, Rajathar, for joining us, and over to you.
Thank you very much, Animesh. Warm congratulations again to Dr. Animesh Saha and Dr. Pradeep Mandal for coming up with this initiative. Dr. Parikh, thank you for the kind words that you had for me. It's been an honor to meet you whenever I have met you, and it gives me great pleasure to meet you after the pandemic. I am trying to share my screen. What I have been asked to do today is to give a talk on screening for lung cancer. And I just need to, sorted. So what I'm going to do over the next 17 odd minutes is to give you a brief about where we stand with lung cancer screening today. And I will conclude with my impressions of where we stand today with lung cancer screening in India. So that's what's in the ambit today. Those are the learning objectives that you hope to achieve out of this talk. We will talk about the CT screening principles and the evidence that's available today. We will talk about some of the non-invasive diagnostic approaches. And we'll also talk about something which is close to my heart. There's a lot of procedures that we can do in pulmonology today, and that's a great addition to our armamentarium. But we also need to make sure that we don't go overboard in the use of these procedures and interventions, and hence we'll discuss about how to minimize procedures. I'll do my talk in the way of certain questions. These will be rhetorical questions because this being a virtual meeting, I cannot see all of you. However, do ask yourself these questions as I go along, and I'll try and give you an evidence-based answer to these questions. So the first question that I pose to all of you and to myself is 5 or 10 year survival a good measure of how effective screening interventions are, because it means more people are getting cured? You would say this is common sense. If the 5 to 10 year survival is good, it means we are doing well with our screening interventions. So let's see what the evidence shows. So if you look at the randomized controlled trials from the 1970s, and I have listed some of the RCTs that were done during the time, it would show that either chest X-ray or sputum cytology or a combination of these two interventions in male smokers above the age of 45 years seem to increase the yield, the positive yield, the diagnosis of lung cancer by about 20%. So 5 year survival would improve from 35%, from 15% to 35%, which would be a 20% increase in survival. So 4 trials, you would feel that the 5 year survival is improved. However, if you look at this meta-analysis in the forest plot therein, you would find that these studies and a few others done during this time period does not really show an improvement in mortality. What's the reason then? And the reason lies in the 3 biases that I'm going to talk about in the next couple of minutes. The first of them, the one which probably comes to common sense first, is about lead time bias. So think of this scenario where you've got 5 patients, which are enumerated by the circles that you see on there. These patients are followed, these patients get symptoms. So there's 1 patient out of these who develop symptoms. The symptoms lead to a diagnosis of lung cancer. And then with or without treatment, the disease goes through its natural course and the patient dies. So this is the control group, the group which has not been subjected to screening. Now you have a second group where you do screening. So same 5 patients, you've now screened these individuals for lung cancer. There's no question of symptoms because you've caught them early. So the diagnosis is confirmed early. However, the patient then dies at the same time frame. If you think about survival time in the control group, the survival time is from diagnosis confirmed to patient dies, which is a shorter period of time as compared to confirmation of diagnosis to patient dying in the screen group. However, you understand that this is an artificial increase in survival time because the survival time looks artificially longer because you've diagnosed the patient early because you screened this group. So the 5-year survival is biased here because of lead time bias. And the lead time is as you see on that particular screen. The next bias I'm going to talk about is length time bias. So length time bias is based on the fact that you have tumors of various grades. You have aggressive tumors and then you have indolent tumors. The more aggressive the tumor, the more early detectable the patient is, and the earlier is the onset of symptoms in these individuals. The more indolent the tumor, the greater the amount of time before detection and for the onset of symptoms. So hold that thought and then see what shows up on length time bias. So if you screen patients at 1-year intervals, so if you see patients at year 1 and then at year 2, it's the patients who have indolent tumors who would get caught in the 1 to 2 year time period. So that's the time span in which you would get the less aggressive tumors. The more aggressive ones would fall on the left of that curve, on the left of that graph that you see in front of you, and wouldn't actually reach the screening period. Hence, you get a false impression that patients are surviving longer because of the indolent or less aggressive nature of the disease, which leads to the length time bias that I spoke about. And see these 2 lines there, those are the tumors that you're catching. These are the less aggressive or the indolent ones, which results in length time bias. The third bias is about overdiagnosis bias. So in patients who are getting screened, so the top group on there, you see that on my cursor on there, you are screening these individuals. Diagnosis happens in all the 3 individuals who are being screened and have lung cancer. One of these patients are dying. The remaining 2 are dying from natural causes, maybe from an MI, maybe from a COPD exacerbation, etc. However, all these patients are getting labeled as having deaths with lung cancer contributing to it. You see the other group, the one which is not being screened, and in this group, there's onset of symptoms, then a diagnosis, then death. The other 2 patients are not getting diagnosed because they're dying before diagnosis from natural causes, which might be, like I said, an MI, a stroke, or a COPD exacerbation. So that's the overdiagnosis bias. So 3 different biases we spoke about. The first is the lead time bias. The second is the length time bias. And the third is the overdiagnosis bias. So let's answer the next question, which is, does lung cancer screening work? So this is the lung cancer screening trial data, which is about more than 10 years dated now. And it compares low-dose CT with chest radiology. You can see the absolute numbers on there. The number of lung cancer deaths, 346 versus 425. The lung cancer mortality per 100,000, again, smaller in the CT group as compared to what is in the chest X-ray group. And you have a p-value which is significant. And compared between CT and chest X-ray, this seminal trial showed that you did improve survival. You would reduce lung cancer mortality by using lung cancer screening. So not survival, but reduction of mortality by lung cancer screening. And you can see the number needed to treat there. So if you screened 320 people, you would prevent 1 lung cancer death. Now, let's try and answer this next question. And I want you to pick your brains again before I give you the answer. All-cause mortality is reduced in breast, colorectal, and lung cancer. Do you think that's a correct statement, or do you think that's an incorrect statement? Now, keep in context that screening procedures, screening protocols are in place for breast and colorectal, which is why we are comparing it with lung cancer screening. So I would have loved to know what your thoughts are, but let me give you the answer. So what about lung cancer? So this is again the NLST trial, the National Lung Cancer Screening Trial data, and this shows a 6.7% reduction in all-cause mortality by doing CT as a screening modality as opposed to doing chest X-rays. So 6.7% reduction, which is a P of 0.02. Let's now compare this with the Cochrane systematic review for breast and colorectal, both with a 13-year follow-up. And I was amazed to see that the hazard ratio is close to 1 or 1 in both of these conditions. Hence, there is no reduction in all-cause mortality by screening of breast and colorectal cancer at 13 years. That's what shows up in the Cochrane systematic review. So this slide is not to pull down the screening procedures for breast cancer and colorectal, but just to say that there's a lot of justification in screening patients for lung cancer if you have appropriate tools and protocols in place. So NLST, why do we pull down NLST? Why is NLST thought to be not so convincing? So the people who designed, and this is from an editorial which came out with the NLST data, this was because the people who designed the National Lung Cancer Screening trials actually did not believe that the trial would come back as being positive. They thought it would be a negative trial, which is why the screening got stopped after 3 rounds. So no follow-up after 1 year. Screening was across the board. It was everyone, and hence even low-risk individuals got screened. There was over-referral for nodules to clinical teams. There was hence a lot of surgery even for benign lesions. They did not use the best nodule evaluation techniques because nodule evaluation techniques have gradually evolved over a period of time, and there was no fixed workup strategy. Hence, the conclusion was from LLST that while it's very promising, while we thought this would be something that would work in the long term, it was also thought that there could be procedures which would make it better. And one of the subsequent trials which I'm quoting here is the Nelson trial. So this was not chest X-ray versus CT. This was screening with CT versus no screening at all. The screening was between 50 to 75 years. It was for smokers or ex-smokers within a span of 15 years of quitting. The CT was done at 1, 3, and 5.5 years. So much longer period of follow-up was done. The numbers were smaller as compared to NLST, with about 15,500 people randomized and about 8,000 people in the screening arm. So that's Nelson. I'll come back to Nelson in a moment. But these are the various guidelines and protocols that have come out in the US. And I want you to look at a degree of commonality in the recommendations from the US, just to remind you guys that it's only in the US and in Canada that there are national screening programs for lung cancer. So you see the pattern, it's mainly above the age of 55 and below the age of 80, or ideally below the age of 75. There's a lot of pack years there is. The quit period should be less than 15 years across the board. And in other risk factors, they have not really looked at other risk factors. I'll come back to other risk factors. The interval of screening is a year across all the recommendations in the US. One of the reasons why these lung cancer screening trials have been pulled down, and this is especially relevant in India, is that it was thought to have a lot of false positives. So Margaret McCartney, who writes articles in the BMJ on a regular basis, had this quote: most countries have hesitated to introduce lung cancer screening because of the eye-wateringly high false positive tests. And one of the proponents of lung cancer screening in the UK, David Baldwin, tells us, no, it isn't. And let me show you why he says this. So these are trials which came in after the National Lung Cancer Screening Trial. It includes Nelson. It includes the UK Lung Cancer Screening Study. And for all of these, you can see that the false positive rate is far lower as compared to NLST. So with NLST, it's about 23%. With Nelson, with UKLS, you're talking about less than 5%. This is because Nelson, the UK lung cancer screening trial, had an intermediate group. So this intermediate group of people were followed up for shorter period of time because the CT appearance were akin to benign lesions. Hence, they were followed up twice and then screening would stop and they would come out of the screening trial at that point of time. And that, I think, is the way forward when you screen patients with lung cancer, even in our country. What are the issues with implementation? What are the challenges because of it? Implementation becomes a challenge. All over Europe, cost effectiveness is proven to be the huge challenge. Selection criteria is difficult. I showed you the selection criteria for the US. I'll show you some more in a minute. What radiological techniques to use, the protocols for low-dose CT scans to minimize the physical hazards, the physical harms for radiation is important. Optimal MDT workup and a team which is used to doing lung cancer screening is extremely important. How often or how infrequently you will screen these individuals is important. To plug in a smoking cessation program is very, very important. And to get people to participate in lung cancer screening has also proven to be a huge challenge. So those are the issues with implementation that one needs to think of.
2 minutes left, sir.
Sure. So these are the risk prediction models that I spoke about. And I want you to look at the model that I'm pointing out, the Tamimagi model. This had a huge number of suspects. However, they were aimed at ever smokers, age between 55 to 74, a BMI which was essentially low, patients with COPD and emphysema, a positive family history, low levels of education, and a personal history or a family history of cancer. I want you to remember this because that's the thought that I want you to hold when we talk about screening in India for the last slide. So large number of patients, ever smokers, 55 to 74, BMI being low, COPD, emphysema, positive family history, personal history positive, and low levels of education. I'll touch on volumetry because of the lack of time. So volumetry is looking at the volume of the tumor rather than the maximum diameter, which we often use. And even very small changes mean that the volume increases by about 25%. Hence, when you look at nodule algorithms today, a lot of them have replaced the diameter, the size of the tumor by volume. And that's what showed up, that at discharge on CT surveillance, make sure that we measure volume, and an increase of volume by more than 25% is thought to be relevant in these individuals. So let me skip a few slides. Very important to think about physical harms. And I show you this slide, which says 1 radiation cancer death for every 22 prevented. So that's a significant number. And that's why selection of patients is important. So 1 radiation cancer death for every 22 prevented. Smoking cessation should be integrated. If you put people into screening programs, the number of people who quit smoking automatically increases, and hence smoking cessation should be an important part of screening trials. I'll finish off now with the approaches and how you go about following up these nodules. So the diagnostic assessment, of course, includes the investigation, the doctor looking at the patient, doing spirometry, lung function tests, and fitness assessment. You would do a CT of extending from the neck up to the pelvis for staging of the disease, and then have a discussion with informed consenting of the procedures that you're going to do. And we said that you do the minimum diagnostic procedures to get the staging information. And then there's a lot of focus on this slide on PET-CT in trying to identify whether these nodules light up and need further follow-up and screening. The invasive diagnostic tools in pulmonology like TBNA, EUS TBNA or EBUS TBNA, FNA of the neck nodes based on ultrasound, etc., are investigations that you might want to do in diagnosing this condition. So let me finish off with my take on the application in Indian scenario. So in my understanding, because of the biomass hazard, because of a younger COPD population in our country, because of air pollution, the screening in India should be at a lower age. And I think somewhere between 40 to 50 would be an appropriate age to start off. COPD, a personal or family history of cancer, etc., are important tools that you include in the screening studies. You try and minimize false positive. We talked about having an intermediate group. In India, this is likely to be a large group. These will need to be followed up for 1 or 2 years. However, there would be a large number of lesions which look essentially benign, and we need to have an algorithm which integrates the intermediate group rather than all these nodules being followed up on a long-term basis. We talked about trying to minimize procedures. Choosing the least invasive approach is important. And there are new techniques which are applicable in select few. However, you need to have tertiary care centers to refer these patients onto so that the best care is available in following up the nodules that you think are essential to follow up. I'll stop there. I think I might have exceeded time by a couple of minutes. And I want to thank the organizing team again and thank everyone on behalf of the Indian Chest Society for having involved us in this great meeting. Thank you, Animation Pradeep.
Thank you, Rajada. I think we've got a couple of comments from Dr. Purvesh Parikh. One of the comments is all-cause mortality in any screening trial always there up for controversy. Throws up. The way events are censored can allow statistical jugglery and confuse us if we are not careful to read the supplementary data. Any comments on that, Rajata?
So absolutely, Animesh, so couldn't agree more with Dr. Parikh. I think that's how they found out about these biases when they looked at the meta-analysis of the 4 trials that happened between 1970s and 2000. And that led to the discovery of these different biases that I talked about. And I guess statistical jugglery is something which is close to the heart of researchers, and numbers can be twisted to suit needs, that's for sure. But I think it's important to understand that going forward, we will need to find out a rational way in which we operate the lung cancer screening program in India. There should be a choice in our country because there's both private and public healthcare. But I think we need to find out a way in which we screen patients. And there, looking at the data, I think would be based on mortality data rather than looking at survival data.
I think many of the private hospitals are coming up with these screening packages, but I think from the government perspective also, we need to take initiative that this is something, it's an urgent need or unmet need that needs to be addressed, isn't it? So
Animesh, we are in the middle of, from the Indian Chest Society, we're in the middle of coming up with a white paper. We've got some people from the government who are associated with it. So this will be a sort of a pilot where we offer lung cancer screening to the population that we spoke about a little while ago. And it will be a small number of people and we'll see how it works. But I think we have a long way to go before we can lay out a comprehensive lung cancer screening trial, a lung cancer screening program in India. But it's definitely the need of the hour for sure.
Very good, very informative. Thank you, Rajada, for the elaborate talk. I think if any participant have any question, you can put up your question on the question answer box, and the panelist or the speaker can try to answer that question, or we can discuss any burning question over the meeting if there is any. So we'll be moving on to our next debate. So we've got a debate. We all know that for early stage lung cancer, for young fit patient, surgery is the primary treatment. And for medically inoperable patient, we do offer them stereotactic radiotherapy. But if you look at the outcome, surgical cohort always show better outcome because their cohort always contain younger, fitter patient. On the contrary, a radiotherapy cohort always have older patient with multiple comorbidities. So they end up showing poorer outcome. And there has been trials comparing head-on SBRT with surgery with a conflicting result. So here we are to discuss about it, whether SBRT is equally effective treatment for stage 1 non-small cell lung cancer compared to surgery. So bear in mind, these are medically operable patients. That's the topic of discussion. We have Dr. Rajkumar Srimali for the motion. Dr. Srimali is a senior consultant clinical oncologist working in Arden Cancer Center, University Hospital, Coventry, and Warwickshire, NHS Trust, UK. Dr. Srimali has numerous publications in national and international peer-reviewed journals. He has been part of many national and international clinical trials, and Sir has pivotal role in setting up lung IMRT and SBRT services in Eastern India. Sir has always been my teacher and my mentor. I'd like to welcome sir. So over to you, sir.
Thank you, Animesh. Trying to get this started. Bear with me.
The backup.
Bear with me a minute. Yeah. Can you see my slides?
So we can, yes, sir, we can see your slides, sir.
Okay. So yes, thank you, Animesh, for your very kind introduction. SBRT or Saber is equally effective for stage 1 non-small cell lung cancer compared to surgery, and I'm going to speak for the motion. It doesn't seem to be moving. So I believe we all know what Saber is. It's extremely hypofractionated radiotherapy delivered in a small number of fractions, BED more than 100 gray, and proper accounting for tumor motion, precise contouring of tumors, and precise dose distribution needs to be carried out, and very accurate dose delivery, either using volumetric image guidance or fiducial based. We all know what stage 1 non-small cell lung cancer is. So before we start off, there is a saying that you need to keep your, well, the saying goes you need to keep your enemies close, but we'll say we need to keep your opponents close for this because we don't have any enemies. So what is the status of surgery? Well, surgery has been around for decades now for stage 1 as well as stage 2 and even 3A lung cancers. And there have been many studies published. It comes with a 30-day mortality and a 90-day mortality. And there are numerous reviews of surgery published by the surgeons that confirm the 90-day mortality to be between 5 and 10%. And although lobectomy is the standard of care, some patients end up getting bilobectomy. And although it is very rare for stage 1s, some patients also end up getting pneumonectomies. So up to 20% of patients who are being considered for surgery, they're either not able to undergo because they are not fit enough, and the anesthetist would not allow the surgeon to get near the patient, or the patients refuse when they find out about other options. And the complication rates are not trivial in older patients with high comorbidity scores. And again, after receiving surgery, up to 5% patients will have chronic disabling pain syndromes. And then the surgeons talk about tissue diagnosis. So what is the reality? Well, excellent local control for surgery and Saber makes it irrelevant. Molecular markers are not useful in stage 1. And interestingly, I have seen over the last few years, once the surgeon will push for tissue diagnosis, but once the patient develops a local recurrence, if it's beyond 2 years, they keep arguing it's a new primary. And if the MDT agrees that, then previous histology is not something we can use because if it's a new primary, it's a new primary. And again, if somebody gets a recurrence, tissue diagnosis can be obtained at that point, or a salvage resection could be carried out. What is the status of Saber? So the outcomes from Saber, again, they have the head-to-head comparison in randomized studies have not been successful because patients, not sufficient numbers of patients have been accrued to these studies. But in single arm and prospective studies, as well as retrospective series, the outcomes are actually comparable to surgery. 5-year control rates around 90%. So it is well established in patients who are medically inoperable, which means they are inoperable because the patients are not fit for surgery. It is recommended by several international guidelines. So that bit is established. Now coming to operable patients, which is the topic of this debate, randomized control trials have been set up, and there were 4 trials. All of these have failed to recruit patients. Why? Because Saber is a radical change from the established standard of care at the time, which is surgery, the contemporary standard of care. And again, both these options have been available to patients. So patients can actually choose between surgery and radiotherapy. And most patients will have some bias of they either want a surgery or they don't want surgery or they want radiotherapy. So if these options are available, they don't like the idea that this will be chosen randomly for them. And at least in Amsterdam, the thoracic surgeons who helped set up the Roselle trial eventually failed to participate or recruit patients because a service optimization review was run at the same time, and there was a risk of reducing the surgical service within the country. So Joe Chang from MD Anderson carried out a pooled trial data analysis. It's a small number of patients. It's 60 patients, 58 patients, and 1 year survival with Saber was actually higher than surgery in this pooled analysis. And 3 year overall survival was also superior. So when we see this, the survival curves, Saber is actually higher and surgery is dropping. Now this is very provocative, and this is counterintuitive because we are groomed to believe that an operation takes the cancer out and shouldn't be any worse. So there was small sample size and there's a shorter follow-up, so this data has to be interpreted with caution. And also very few events occurred. The follow-up was limited, and the survival in Saber was better than expected in these two studies. And again, salvage surgery is possible in Saber failures, so that can have an impact on that. However, this study actually confirms the equipoise that either of them are not worse than the other. So where are we now? We should recruit more patients in studies. Now this is an important concept for radiation oncologists to understand propensity score matching. And this is something that in the last couple of years I'm reading more and more about. So it is a useful method where randomization is not possible, either logistic reasons or ethical reasons. And the researchers use statistical techniques to construct an artificial control group where the treatment characteristics are matched. And the propensity score matching has actually helped the Saber cause. So after the failure of the STARS trial, the team at MD Anderson then carried out a single arm prospective study where they took they actually maintained, sorry. Yeah. So it was a prospective study where additional 80 patients were recruited, and then they identified comparable controls from the same institution, from their own registry. And this was designed to test a 3-year overall survival. And because the MD Anderson has a high volume thoracic surgical units, they actually did not have any mortality or significant morbidity. And in this study, kind of getting stuck. Yeah, so with a median follow-up of over 5 years, the overall survival with Saber was impressive. It was actually comparable to surgery. There was no significant difference. There was a higher rate of regional recurrence, which means nodal recurrences in the Saber group. And again, we have to be mindful that surgical patients have nodal upstaging. So 10% of surgical patients, if they carry out a mediastinal nodal resection, they'll find node positivity, and then they are then moved from stage 1 to a different stage. So that was that. Reassuringly, this study also showed that people who get isolated regional recurrence following Saber were effectively salvaged with subsequent treatment. So the challenges with randomized controlled trials have been ongoing. A few studies have failed, few are ongoing. This is a retrospective data from a single large UK center, 468 patients, some with surgery, some with Saber. And what this study showed, this is real world data. So what they showed was there was no cancer-specific, there was no difference in cancer-specific survival and combined cancer and treatment-related survival. So these are Kaplan-Meier curves. The first curve, where surgery is shown to be better than Saber and standard radical radiotherapy. And with the second one, we are looking only at the cancer-specific survival, and the lines, the curves for surgery and Saber are kind of overlapping. This is more of the same, is essentially the causes of death. So systematic review is the best evidence in the absence of randomized trials, and this is a large systematic review with over 3,700 patients for Saber and over 2,000 patients for surgery, and the 2-year survival were comparable the Saber was equivalent despite the comorbidity. And the criticism would be that this is non-randomized. There's a risk of bias. The surgical groups are an earlier group. There was stage migration. But on the whole, this confirms the equipoise, which is the topic of this debate. Meta-analysis, another meta-analysis, 40 studies for Saber, 23 studies for surgery. Median unadjusted results were not comparable because there was a significant difference in populations between the patients who underwent Saber and surgery. But when the patient profile differences were adjusted, SBRT was found to be non-inferior with respect to survival. Population analysis, again, proportional hazards regression and propensity score matching was used to compensate for confounders. And with well-matched cohorts, sublobar resection was worse than lobectomy, but Saber was comparable to lobectomy. 90-day mortality was 4% for lobectomy and 1.3% for Saber. And again, the Saber patients are likely to be in their 80s, the females, higher comorbidities, some require supplemental oxygen, poor performance status, they're more likely to be PET staged, and also when they're treated, they don't actually get mediastinal staging procedure in the population analysis, but we know that EBUS is now widely used. Subsequent SEER study, again, no difference in 2-year survival, 70% versus 68%, no difference in local control. So differences in the groups, the less invasive lymph nodes with Saber, no lymph node dissection, could have been harboring occult nodal mets. With surgical cohort, they get more therapy, shift in stage, and then subsequently, because of shift in stage, adjuvant therapy is also a possibility. Economics-wise, the actual cost of Saber is about half of lobectomy. So lobectomy could become cost-effective only by producing more quality adjusted life years. But by and large, Saber is actually cheaper and doesn't require the same kind of infrastructure. So the surgery, the goalposts are shifting because the sublobar resection is now creeping in, while segmentectomy is a surgical procedure, wedge resection isn't. So is Saber equivalent to sublobar resection? This is a publication from the Christie at Manchester. There's no randomized data. Prospective studies were compared, and 1-year survival was similar between Saber and sublobar resection, and 3-year survival was higher with sublobar resection. So what do the patients want? So there was a study that was published a few years ago that was carried out over 102 patients, of which 89% of the patients participated, and nearly 80% patients said they were more satisfied with Saber than with surgery. And this is possible because of the 102 patients, 41 patients had prior surgery. And of those patients, 89%, they said that they would have rather had Saber even earlier, but they didn't know that that option was available. So it is important that the patients are informed.
So 2 minutes left, sir.
Thank you. So basically, this was the question. If you can decide now, would you rather have SBRT in place of your surgery in the first place? And up to 90%, nearly 90% said yes. So quality of life, the red line for Saber is higher for the global health status, whereas the blue line for surgery is higher with dyspnea score and pain score. So this is straightforward. Now, both of these treatments result in decline in lung functions. So with lobectomy, the decline in lung function is up to 16%, with sublobar resection, segmentectomy up to 11%, with Saber, it is up to 6%. So, and with the surgical, the patients had good reserves, whereas with the Saber, we often have patients with poor lung functions. So in spite of that, we had a less decline. So what's happening in the real world? Well, this is a publication not very long ago, 2018, and they have looked at data from 2004 to 2012. Radiotherapy increased from 13% to 29%, surgery declined from 76 to 61%. And that's a different study with similar graphs. Yes, there is an argument that very conformal radiotherapy with Saber causes very conformal fibrosis, but with the use of PET in follow-up, I think that problem is being looked at. So summarizing, primary tumor control rates are around 90% or more. With Saber, 3-year survival is comparable to surgery. Outcomes are widely reproducible, and Saber is not dependent on high volume centers. It's very convenient, outpatient, no need for anesthesia, no need for hospitalization, safe and well tolerated, even in elderly and frail patients. There is less decline in lung functions. There are no issues of chronic disabling pain syndromes. The 30-day and the 90-day mortality with Saber is close to 0. There is minimal impact on the patient-reported quality of life because that is clearly favorable with Saber. There is less decision regret. So if a patient has had surgery before and Saber subsequently, they would have rather had Saber in the first place. Now, this is the question. Despite the local risk of local recurrence and occult disease, we could improve on surgery. Now, organ preservation is widely used in larynx, bladder, prostate, breast, anal cancers. So I think we need to at some point propose a trial where patients get upfront Saber with reservation of surgery for salvage, and VATS could be used. So that should be the way forward for a prospective study. So summarizing, safe and effective, excellent local control, never been compared to surgery in a fair manner. Our randomized control trials are necessary, but they don't seem to recruit. So we should have a trial with upfront Saber followed by salvage surgical resection. Until then, we can argue that it's equally effective. Thank you.
Thank you, sir. Thank you for the elaborate talk. I think we've got a question from the audience. I think Dr. Jappy Agarwal is in the delegate. So, sir has asked, which patient would you refer for surgery rather than Saber?
We in the MDT within the NHS, we don't refer patients for surgery. So the patients are discussed at the MDT, and often if they are eligible for both, they get given the option for both. Clearly, patients who have stage 1 lung cancer within 2 centimeters of the main airways, currently Saber is not routinely used within the NHS for central disease outside of a clinical trial. For everything else, if it is feasible, we tend to offer Saber, but we tend to use what is called a Herder score. So everyone gets a PET scan. So either they have to have a Herder score with the probability of cancer more than 80% if they don't have histology, or they have to have a clearly growing disease on 2 consecutive CTs. And then we can offer Saber. Some patients will opt for surgery, others come for Saber. There is no constraints in terms of lung function tests. Yes, if somebody has extensive interstitial lung disease, then we don't tend to use it.
So I think we should move on to our next debater. We've got Dr. Robin Thambodorai. Dr. Thambodorai will be speaking against the motion. Sir is a senior consultant, thoracic and GI surgeon, Tata Medical Center, Kolkata. Dr. Thambodorai has been one of the lead thoracic surgeons in Eastern India. I'd like sir to take the proceedings, sir. Over to you, sir.
Dr. Robin, you'll have to unmute.
Yeah. Can you see my slides?
Yes, sir, we can see the slide.
Okay. So it was good to see Raj after a really long time. Raj used to be my colleague at Tata Medical Center, very passionate radiation oncologist, but unfortunately, I'm going to have to disagree with him. Now, I want to start by saying that I have absolutely nothing against radiation therapy being offered as a primary source of treatment. But before I start, I just want to give you a little bit of background. This is actually my background with regard to this debate. The first time I heard this debate was in 2009, and most recently in the last month. Actually, that should have been 2022. So clearly, if we have been debating this for over 10 years, then there is a problem. And the problem is that there is whatever literature we see, there is a lack of robust evidence in favor of SBRT. Then the other thing that Raj referred to, and the issue of occult mediastinal nodal metastases, SABR does not address this question. SABR cannot be given to all stage 1 tumors, depends on the location of the tumor. Further, and I've looked at this in literature, there's no actual uniform definition of what constitutes local control. following SBRT. Third, second last, distinguishing radiation-induced lung injury from recurrence can be very challenging. And most importantly, and which may not be a problem in the UK or in many developed countries, but this requires intense follow-up. In a center like ours, where we get patients from all over Eastern India, Northeastern India, Bangladesh, Bhutan, it can be challenging to have patients go through this kind of follow-up. Just refer very briefly to two meta-analyses, Chen et al. 2018, combined results of 16 propensity score studies comparing surgery and stereotactic ablative radiation. Overall survival favored surgery. Jetilo et al. 2019, 792 patients, more than 65 years of age with clinical stage 1, underwent VATS lobectomy or SBRT. Propensity matched comparative analysis, median overall survival rates were significantly better in the surgical group than for SBRT. Now, we looked at, Raj looked at some of the trials that were tried and which didn't work. And I'm just going to refer to 4 trials, 3 of which are ongoing. And I think these may actually answer the questions. The VALA trial in the US, the Veterans Affairs hospitals, where they're going to be looking at operable stage 1, less than 5 centimeters, peripheral or central. They're going to be stratified stage A, 1A versus 1B, central versus peripheral, and then randomized to lobectomy or segmentectomy, and stereotactic radiotherapy. And the endpoint is going to be overall survival. In this trial does not permit wedge resections, which are not really a cancer operation. They estimate that they will enroll 670 patients. The estimated primary completion date is going to be September of 2026, and the study completion date is going to be a year later. No interim results have been published. Then the stablemates trial, again in the United States and Canada and North America, estimated enrollment is 277 patients, studies to be completed in 2024. The primary outcome, again, overall survival. Then there is the post-live study in China. It's a small study with an estimated enrollment of 44 patients. Primary outcome measure is going to be loco-regional control with overall survival, among many others, as a secondary outcome measure. And then I'm just going to go back to the Sabertooth trial in the UK. This was not really a trial to see whether they can compare SABR with surgery, but to see if they can actually do an RCT. It was more like a pilot study, as far as I can understand. They wanted to enroll 54 patients, 3 patients a month in a 7 to 21 month period. And it was supposed to be completed in 2017. The primary outcome measure was the achievement of a steady state of recruitment. So what did they do? 318 patients were considered. 106 patients were assessed as eligible. Only 24 patients were randomized. 14 to Saber, surgery 10. Only 15 patients underwent allocated treatments. Saber 12 and surgery 3. And the conclusion from this trial was that an RCT on this cannot be performed in the NHS. But the trial that I'm most looking forward to is this Canadian trial by DiPalma, the missile trial. It aims to enroll 40 patients. This is a slightly different trial because what they plan to do is they're going to give SBRT, and then all patients 10 weeks after completion of radiation are going to undergo surgery. The interim results were shared at a conference in Toronto and published in JAMA Oncology in 2019. And they showed that the pathological complete response rate was only 60%. That means 40% of patients still had viable tumor. This study is due for completion in September 2022. Incidentally, the combined approach had toxic effects comparable to the series of surgery alone, and there was no perioperative mortality. Further studies are needed to evaluate this combined approach with surgical resection alone. So in conclusion, I still stand by the fact that SABR is appropriate for medically inoperable patients, patients who decline surgical treatment, patients who do not have access to surgical services. As knowledge and technology advance, Saber may have a more prominent role to play in the future. But in today's date, to say that Saber is an equally effective treatment does not comport with the currently available evidence. Thank you.
Thank you, sir. Thank you for your presentation. I think we've got a question from Dr. J.P. Agarwal, sir, to yourself. So, which patient you will refer to SBRT, refer for SBRT rather than surgery? I think you have answered the question. If you just
Yeah, so I mean, it's not just for stage 1. We discuss the definitive radiotherapy or chemoradiotherapy option with all lung cancer patients. Patients who I would definitely not consider are patients who would be medically inoperable, which means don't have very good lung function, have multiple comorbid illnesses, patients who you don't think can withstand the stress of a surgical endeavor.
I think we'll have 1 or 2 comments from Dr. Srimali as a rebuttal and yourself, if time permits. So, Dr. Srimali, sir, if you're there, any rebuttal comments, sir?
No, I think it was a good debate. I think we've said the same things. We have talked about the trials that have not recruited. Until we have a randomized controlled trial, it is hard to, we can keep arguing until the cows come home.
I think Dr. Srimali, yeah.
I'd just like to make 1 or 2 points though. While a lot of this mortality data has gone back in time and looked at large numbers of patients, these things are actually changing with time. I can tell you that in Tata Medical Center, we have a mortality rate of less than 1%. Okay. And we do some pretty old patients. The oldest patient we've operated on was 83. Okay. And so mortality rates are not so bad. And the other thing, with the advent of minimally invasive procedures, although we don't do them where I am, but the issue of pain is slowly going to become a thing of the past with VATS lobectomies, robotic lobectomies, although, maybe many patients won't be able to afford them. But pain as an issue is no longer, I mean, we don't really see patients with chronic disabling pain syndromes.
Yeah, okay. Now, what I would say is we are working in different practices. I agree. I mean, the surgeons at Tata Medical Center are very sensible and are not as aggressive as some of the other surgeons I've seen in my practice. But I have seen aggressive surgeons, and I have seen morbidity and mortality. I have seen people canceled from surgical lists because they had a PE the night before or 2 days before. I have seen people go into MI in the post-operative period. I have seen people who have had 2 sabers 3 years apart and have had a 3rd lesion. So there is a limit to how much surgery somebody can get. So I think there's as the services evolve, as the services mature, and as the survival improves, we will have patients who will at some point have multiple modalities of treatment. And there are people at different ends of the spectrum, people who are very aggressive and a bit maverick. So yes, I mean, I agree with Robin. I mean, the surgical outcomes at Tata Medical Center is very good, but I can't say that same is the true for everywhere. And I have seen some of these morbidities and mortalities, and in the mortality meetings, I've seen cases discussed. So it is not a thing of the past, but yes, that's where we are.
But I think
one comment, sir. Dr. Srimali has all.
I'll just make one last comment.
Okay.
In the future, I think I find this missile trial very exciting, combining SABR with surgery. Okay, and it may be even better than either modality alone. I think we should wait and watch.
Dr. Srimali has mentioned that he's not willing to treat patient with SABR who have got interstitial lung disease, particularly the fibrotic pattern, the UIP, or the
severe UIP.
So, any thoughts on surgery to this patient, ILD patient?
Yeah, so we've done surgery on ILD patients. So we don't go so much by what their baseline pulmonary disease is. We go more by their pulmonary function. So they need to have a really good assessment of fitness. If they meet that criteria for the assessment of fitness, we've actually done lung resections in patients with interstitial lung disease, and they've done pretty well, and they're still on follow-up. Okay, but obviously it's not for all patients. It's only for those who meet a pulmonary function fitness criteria.
Yeah, any patient with more than mild to moderate interstitial lung disease, we actually push for surgery if the lung functions allow. So yeah.
I think we have to conclude here. We are running behind time, so we'll move on to the next session. Thank you, sir, for the debate. So we'll move on to our next session. This is an interesting one. So we know till a few years ago, neoadjuvant and adjuvant treatment was based on only chemotherapy and radiotherapy. But newer trials, the newer data has shown that addition of targeted therapy, novel agents, and immunotherapy has dramatically improved the outcome. And we've got some promising result which has come up very recently. And to enlighten us on that, we have none other than Dr. T. Raja. Dr. T. Raja, sir, is a senior medical oncologist and director of medical oncology, Apollo Cancer Center, Chennai. Sir has got more than 26 years of experience in the field of oncology. He's the head of the department, and he's the head of the DNB medical oncology program, Apollo Hospital, Chennai. The distinguished clinical tutor in medical oncology. Sir is an active member of major oncology groups in the country, including ISMPO, ICON, and ISO. Over to you, sir.
Thank you, Dr. Anish, so much for it. Very kind invitation. Dr. Animesh, my slides are visible and audible, correct?
Yes, sir.
Thank you. I thank the organizers for this kind invite, and I'm happy to be with you all. And thanks, Dr. Animesh, for giving me this interesting topic, newer paradigm of neoadjuvant and adjuvant treatment in resected or resectable lung cancer. So I'll begin with a couple of slides from Professor Goldstraw's paper in thoracic oncology in 2016, where he shows that 5-year overall survival outcomes decrease with increasing stage in resectable lung cancer. As you look at the stage, there is a significant decline as the stage progresses, and the 5-year overall survival dramatically drops to 60 immediately at stage 1B, and in 2A it's already 60, and by the time you cross 3B, it is 26%. This is true not only for clinical stage, as he has shown, and he also shows that pathological stage, and these are the survival curve for pathological stages. So there is definitely plenty of room for improvement with surgery alone. That's basically because in spite of surgery, there is plenty of recurrence rate. In early lung cancer, definitely the recurrence rates are high. And if you look at stage 2, already there is a recurrence rate of 62%, and stage 3, we have a recurrence rate of 76%. So we need to consider what other factors we can do while we want to treat these patients of early lung cancer. How do we improve them? Obviously, the recurrence rate worries us, and something special, subset CNS recurrence, and then we look at how do we improve their outcome with either an adjuvant effort or a neoadjuvant effort. But whenever we put on these efforts, we have to look at what is the DFS achieved with these options, and finally, what is the overall survival achieved with such interventions. And then we need to look at safety of such interventions, and finally, the quality of life for the patients. That's how you consider to choose these options. But interestingly, 26, 27 years ago, this was not new. The whole effort of perioperative management around in and around surgery was on even earlier on. Then this is a paper by Dr. Roth in 1994, which showed that perioperative chemotherapy in stage 3A selectively would be better than surgery alone. So that was a paper that was as old as 26, 27 years ago. But then subsequently, number of adjuvant trials appeared. One of the most important one is the ANITA study. It showed that adjuvant chemotherapy in a broad range of stage 1B to 3A non-small cell lung cancer would give an advantage in DFS and in OS by only 5%. 5-year survival advantage, both DFS and OS, only addition of 5%. And a subsequent LACE meta-analysis, which include 5 trials, including the ANITA trial, would show the 5-year overall survival was only beneficial by around 5.4%. And this was again, retrospectively reanalyzed by Dr. Krish in JCO 2017, the 5-year overall survival and the retrospective analysis of absolute benefit of chemotherapy. Here is where you see this. If you look at the absolute benefit in purple, you hardly see that in 1B, but in stage 2, you start seeing that the absolute benefit appears anywhere between 10 to 15%. And in stage 3, you see the absolute benefit of 15 to 20% plus. So that's where the real benefit lies with adjuvant chemotherapy. This is another interesting paper by Dr. Brandt in 2019, where there is a retrospective propensity matched analysis which showed that neoadjuvant versus adjuvant, the DFS and OS are almost the same. The survival curves are superimposable, meaning that neoadjuvant is equal to adjuvant, adjuvant is equal to neoadjuvant. But not not immediately, because if you look at these data carefully, neoadjuvant effort, what happens is 78 to 90% of the patients were able to receive full dose of chemotherapy and all cycles of chemotherapy, whereas in the adjuvant effort you can see only 60 to 70% of the patient would receive full dose or all the cycle. And strangely, the grade 3 side effects were more in the adjuvant setting, probably because of post-operative recovery and neoadjuvant or fresh patients. That could be the explanation. So now look at the adjuvant efforts with the tyrosine kinase inhibitors, wherever there is a receptor-driven disease, and taking the EGFR as an example, EGFR TKIs is adjuvant therapy. There has been numerous trials with both erlotinib and also with gefitinib. They have all consistently shown one thing, DFS benefit, but none of them later on mature to show an overall survival benefit. And for example, this is the Radiant trial for adjuvant erlotinib. When we looked at the intent to treat population, all comers, you would see that the DFS showed no benefit, but in EGFR mutant subgroup, you would see that the DFS is slightly better at 46 months as compared to 28 months with the placebo. And this is the adjuvant or the CTGONG trial with adjuvant gefitinib in patients with stage 2 to stage 3A gefitinib, and in patients who are EGFR mutant, you would see the DFS benefit of the hazard ratio of 0.6. This is the most important trial, ADORA, that we are all looking at now, and this was the early results were available from 2018, and it was well published in 2020. Phase 3 double-blind study of adjuvant osimertinib, and these are the DFS curve. The ADORA shows there is a significant improvement in the DFS, both in the overall population of stage 1B to 3A and in the primary population of stage 2 and 3A. If you look at all these individual subgroups of stage, you see there is a consistent 2-year DFS advantage. And if you look at 1B, the DFS advantage hazard ratio is 0.39, stage 2 0.17, and stage 3A, the DFS advantage was 0.12, which is very, very impressive. And this trial also shows that the recurrences were decreased with osimertinib. If you look at the recurrences with placebo, it was 46%, and the recurrences with osimertinib was only 11%. Again, the number of systemic recurrences was much less with osimertinib as compared to the placebo. So the total number of recurrences and the systemic recurrences were reduced. Again, particularly looking at the CNS recurrence in the adjuvant CTGONG trial, 27% of all the recurrences had CNS involvement, and in the adjuvant Radiant trial, 37% of all recurrences had CNS involvement. We know earlier that osimertinib has got a better CNS penetration because of his blood-brain barrier penetration, so one would expect that this would do well in CNS disease, and this is already shown with the metastatic setting, the efficacy of osimertinib in CNS progression. It was found that 1/3 of patients as compared to placebo would progress in the CNS whenever they were put on osimertinib. So the ADORA trial was also showing that the CNS recurrence rate was very low with the adjuvant. In the adjuvant setting, the CNS recurrences are only 1% as compared to 10% for the placebo. The CNS deficit DFS, disease-free survival, is also beneficial with in the Adjuvant trial. And the time of publication, it was shown that the DFS was not reached and the hazard ratio was 0.18. Consistent that the CNS benefit is very, very good with osimertinib. So based on these trial data, FDA in 2020 would approve osimertinib for adjuvant therapy after tumor resection in patients who have the EGFR mutations, particularly the exon 19 and the exon 21 L85R mutation. And so now we look at what are the adjuvant efforts with immune checkpoint inhibitors. And number of phase 3 trials are on with as adjuvant immune checkpoint inhibitor monotherapy in resected patients with pembrolizumab, with nivolumab, and with durvalumab, and with atezolizumab. The atezolizumab data, IMpower 010, was presented last year in the ASCO, and these are the results for adjuvant atezolizumab in stage 1B to 3A. And that too, these patients, whenever chemotherapy is indicated, have already received chemotherapy and then adjuvant atezolizumab. Post that, and this is the DFS benefit that you see. The DFS is 42 months as compared to 35 months with basic supportive care. And this is for all stage 2 to 3A patients, which was the primary endpoint. But again, if you look at the DFS for patients who have a PDL1 of at least more than 1%, you see that the DFS is not reached at the time of publication with the hazard ratio of 0.66. And therefore, the DFS benefit is actually seen across all subgroup with adjuvant atezolizumab, but they are very amplified in stage 2 to 3A, and whenever they have a PDL1 of more than or equal to 1%. And if you see the survival curve in the intent to treat population, all comers, they are closer, but the benefit is seen to the tune of 12% delta here in the patients who have a PDL1 of at least 1%. And if you look at the subgroup analysis with the adjuvant atezolizumab trial, you see certain striking points. In patients who have an EGFR mutation, there is no benefit. In patients who had an ALK mutation, adjuvant atezolizumab did not show a benefit. But with increasing PDL1, you see that there is a consistently increasing or improving benefit. So the summary for the 010 trial was that significantly improved DFS with atezolizumab given after surgery, after cisplatin chemotherapy, but it was greatest for patients with high PDL1, particularly for PDL1 more than 50%, with a hazard ratio of 0.44. What about neoadjuvant efforts with immune checkpoint inhibitors? And this is the rationale for neoadjuvant immune therapy. It was seen that neoadjuvant immune checkpoint inhibitors given before surgery would demonstrate that post-surgery, you would see that there is a systemic anti-tumor response due to the activated tumor T cells that are still there in the specimen. And this proof of concept was seen early on with the nivolumab data. You see that there is a clinical and radiological response with nivolumab, and again these are the waterfall plots for the responses, and you see that in biopsy before nivolumab and biopsy after nivolumab, that you see the response and you see the T cell infiltration. Based on this pathological response, where then subdivided as is minor, moderate, and major pathological response, and these then turned out to be surrogate endpoints for neoadjuvant trials with immune checkpoint inhibitors. These are the data for the phase 2 neoadjuvant nivolumab, and this is the neoadjuvant atezolizumab, again a phase 2 impressive waterfall plots, and the pathological response rate with nivolumab was actually 20 to 25%, whereas with atezolizumab you would see a neoadjuvant PCR rate of 21%, and this is neoadjuvant atezolizumab plus chemotherapy. And these are the waterfall plot, and you see a major pathological response. You would see at least in some set of 90% is what is seen when you combine atezo plus. But these are all phase 2 trials, and this is phase 2 NADIM trial, neoadjuvant nivolumab plus chemotherapy. Again, major pathological responses 83% and a PAT-CR of 63%. Very, very impressive numbers. And these are the number of trials that are on, wherein neoadjuvant immune checkpoint inhibitors are on. But the one that is already mature and published is the Checkmate 816 data, wherein a neoadjuvant nivolumab this is a phase 3 randomized trial, neoadjuvant nivolumab plus platinum, and this was presented in last year ASCO and the AACR, and this is for stage 1B to 3A resectable patient where nivolumab plus platinum doublet chemotherapy, and post that you would operate within 6 months of completion of 3 cycles of chemotherapy, and then followed by adjuvant immune therapy depending on. And these are the results. The primary endpoints were PAT-CR rate, and you see that the PAT-CR with Nivo and CT PAT-CR is 24%. And particularly in completely resectable patients, the PAT-CR of around 30%. This is something like what you see in breast cancer, in that too in HER2-driven disease or in triple negative, you see PAT-CRs of 30 to 50%. That's what you see with nivolumab plus chemotherapy in non-small cell lung cancer. But if you look at the subgroup analysis, this is what we learned from the Checkmate 816. Across all stages, 1B, 3A, you see the benefit. Across squamous, non-squamous, you see the benefit. Across all PDL1 spectrum, in neoadjuvant settings, strangely, you see the benefit. Even if it's PDL1 low, you see that there is benefit. TMB high or low, you see the benefit. That is something good to learn. But what you also see is that these patients have not been analyzed for presence of driver mutation. So we do not know the answer if these patients have driver mutations, whether neoadjuvant immune therapy will be as beneficial or not. We don't know the answer to that question. And this is the pathological regression according to stage. So the response is as good in across all the stages. This is also something very good to learn from the 816. And again, something more interesting, these pathological responses were followed up based on whether these patients have circulating tumor DNA, ctDNA clearance or not. So in patients who have circulating DNA clearance, you see that the PAT-CR were as high as 56%. So that is something very, very stunning. And you also see that the PAT-CRs were very, very good in patients with a ctDNA clearance, and there were not good PAT-CR without ctDNA clearance. This is again something relevant, whether this is compulsory for us to incorporate in all neoadjuvant immune checkpoint trials or not. We'll come to that later. The summary of 816 trial is as follows, that the primary endpoint of PCR with the addition of nivolumab to neoadjuvant chemotherapy has been met. The primary endpoint has been met, and the PCR benefit is across all subsets, except of course the biomarker-driven disease. But you can't ignore the biomarkers, because in lung cancer, biomarkers are diagnostic, prognostic, predictive. So how can you design anything without biomarker consideration? So we need to take that into our considerations. So therefore, some of the trials are on. This is the Neoadjuvant trial, in which phase 3 trial is on, wherein there are patients with EGFR mutant disease, exon 19 and the exon 21, where you see that osimertinib neoadjuvant, osimertinib alone, osimertinib plus chemotherapy, or placebo plus chemotherapy followed by surgery. This will be a very interesting trial to look at. The ADURA 2 is another interesting trial wherein a select population of stage 1A alone is taken, and these patients should be demonstrated to have EGFR mutation, and then again they should have lymphovascular invasion, and based on that these patients are put on osimertinib. And again, this is very exclusive non-squamous non-small cell lung cancer. So let's see whether this fully selected group will show the best possible outcome with osimertinib or not. That is something to be seen. So this trial will tell us something, whether the osimertinib is going to be beneficial in early disease, even among the resectable disease, versus a slightly bigger stage among the resectable disease. That's the take home, which probably will be available with this particular trial. And this is another very interesting trial that's ongoing, that's known as LCM-C4, wherein available, actionable, all drivers are tested and the patients are identified, and these patients are treated in the neoadjuvant setting with all those interventions, with immune checkpoint inhibitors, with targeted therapy. And this trial is popularly called as the leader neoadjuvant screening trial. Is kind of a basket trial wherein each patient is treated according to their mutations that are seen, And then the results, of course, we are eagerly waiting. This is one such patient. Neoadjuvant alectinib in patients who have an ALK translocation. You can see the clinical and radiological response, and then you see that VAT surgery, and you have a 15% residual viable tumor. That is something like a major path response with the ALK inhibition.
Sir, 2 minutes left, sir.
Yeah, last Kashish. So therefore, now the circle has come to where that whether we have to compulsorily use ctDNA measurements and whether that's going to predict the occurrence of pathological complete response in the perioperative immune checkpoint inhibitor. So therefore, coming to the topic that Animesh has given to me, the newer paradigm of neoadjuvant and adjuvant treatment in resected lung cancer, of course, the paradigm has shifted. It's not anymore surgery alone. There is going to be adjuvant therapy and there's going to be neoadjuvant therapy. Earlier, it was very black and white. You have one or two options. Chemotherapy was the only option, but thankfully, with all these things, now these options have become very colorful. So that's the paradigm shift, and thank you so much for your attention.
Thank you. Thank you very much, sir, for your elaborate and extensive talk. I'd like to have one question. So, sir, whenever we use a novel agent for any newer indication, in India, we depend on DCGI approval. So, have any immunotherapy or novel agent in adjuvant or neoadjuvant setting have got a DCGI approval? Just a query. You're muted.
Sir, your mic is muted.
Thanks, Animesh. I just want to say that I believe that we follow the most of us would copy the FDA approval for our discussion, and patients would be able to take it. Number one, and these agents are already available. These are, the other way around. These agents are approved drug therapeutic options which are available for a different stage and a different setting. So if you counsel, and if there is one major body approval, that should not be a problem in counseling this to the patient. But on the other hand, to specifically answer your question, whether there is a DCGI approval or not, I just want to beg that I may not be knowing the right answer, but the osimertinib post-surgery adjuvant probably has got a DCGI approval. I am not aware whether nivolumab or atezolizumab has been approved either in the adjuvant or neoadjuvant setting. I'm not yet aware of that, Dr. Animesh.
Thank you. Thank you very much, sir. I think we'll move on to our next session.
Thank you.
So our next session is very interesting. So we all aware that for resectable stage 3 lung cancer, that surgery should be done. And we know the option of neoadjuvant and adjuvant therapy before and after. But if you look at the Pacific data, which have used concurrent chemoradiotherapy followed by 1 year of adjuvant durvalumab, the recent data is pretty impressive. So median survival for stage 3 lung cancer is around 4 years now, and 5-year overall survival is around 43%, which is pretty impressive. So the question is whether non-surgical treatment with concurrent chemoradiotherapy followed by adjuvant durvalumab should replace the surgical treatment for resectable stage 3 lung cancer. And for the motion, to speak about for the motion, we've got Dr. Dodul Mondol. Dr. Dodul Mondol is a senior radiation oncologist currently holding the post of Associate Director of Max Super Specialty Hospital, Saket, New Delhi. So over to Dr. Mondol.
Thank you, Dr. Animesh. Good evening, everyone. And thank you, the organizer, for giving this excellent opportunity. So when I initially looked at the topic, I thought it's very simple. But then when I looked into more detail, I saw that it's actually, I have to speak for the motion. And the topic is about resectable stage 3 non-small cell lung cancer. But the current data regarding durvalumab, we all know that the study was actually done for unresectable lung cancer, and we will gradually see what it is. So let us see what actually this stage 3 means. And so in short, N2 disease with early T stage, or N3 disease with early T stage, N2 disease with T3, T4, N3 and T3, T4, T3, T4, N0 and N1. And essentially, when you talk about resectable non-small cell lung cancer, probably we are going to speak about specifically this stage 3A, N2 disease. Now, this is a very heterogeneous group, and there are wide variation in terms of in the T stage by virtue of different organ involvements, and one can go through the staging to see how it is widely variable when we talk about stage 3 lung cancer. So now resectable stage 3 lung cancer and whether surgery is an option, it's really a big question whether surgery should at all be considered when there is really lack of convincing data for surgery. Now, most of the trials or most of the studies where surgery have been utilized, it's actually combination of chemotherapy, surgery, and or radiation. That means someone is actually utilizing multiple combinations of treatments, making the toxicities more, giving more cost to the treatment. So for this stage, surgery essentially remains a controversial area, and it's actually part of a combined modality treatment. And you will see essentially that even in NCCN guideline for stage 3 lung cancer, only a very selective group of population, they are being considered for surgical resection. So this red is actually surgical resection group. All blue boxes are for non-surgical management. And you can see that it's actually filled up with the blue boxes. So I do agree that for a very small group of patients where we have seen or we see tumor nodules in different lobe, where surgery may hold a significant role in the management, but yet radiation chemotherapy remains a component of the treatment. Now, why the role of surgery is so controversial? 4 different randomized studies from 4 different countries, including UK, United States, France, and Japan, they have all failed to accrue the desired number of patients when they try to conduct randomized studies on the role of surgery in resectable stage 3 lung cancer. And essentially, all these studies actually recruited very few number of patients. So we are talking on a treatment modality which actually failed to accrue a desired number of patients across different countries in randomized studies. Let us look at the cumulative data of available randomized studies, which actually compared the role of surgery and radiation. And these are 7 studies, and you can see that all these studies where surgery and radiation were actually compared as treatment groups, there is no significant difference in outcome when you talk about the benefit of surgery, when you talk about the role of surgery or radiation in resectable stage 3 lung cancer. And see the number of patients, it's not very less, 1,322 patients from 6 studies. And it also says that survival was not significantly different concurrent when we compare with concurrent chemoradiotherapy. Within 2 years, concurrent chemoradiotherapy actually showed better survival and less mortality. So in first 6 months, there are more mortality in the surgical arm compared to non-surgical arm. So a treatment which does not give any additional benefit but gives higher mortality and morbidity, I do not think should be a standard of care in today's time. This Spanish group essentially came up with some treatment paradigm, and again you can see that for stage 3A N2 disease, it's all about radiation or combination of radiation and chemotherapy, and essentially surgery holds a very insignificant role in the treatment paradigm. Of course, after a publication of Pacific trial, there is significant role of durvalumab, and we will also see that. So this says that surgical resection after induction therapy is indicated when imaging tests rule out extrathoracic disease progression. Functional assessment after induction therapy indicates that the patient can tolerate the resection, and restaging techniques confirm an improvement of the mediastinal status, and the type of resection ensures a complete resection but avoids a pneumonectomy. So a complete R0 resection for the T and N are both important to achieve R0 resection and a successful surgical outcome, which is not essentially easy. So this URTC randomized study is one of the most landmark studies which actually compared head-on after induction chemotherapy for resectable stage 3A into disease. And it showed that surgical resection did not improve overall or progression-free survival when it was compared with radiotherapy. And it also said that in view of its low morbidity and mortality, radiotherapy should be considered the preferred loco-regional treatment. And we should not forget that it's almost more than a decade. And by this time, the radiation technology has evolved, and now it is even better to reduce the so-called apprehensions of radiation-induced toxicities. A detailed analysis of the URTC study also showed that the mortality rate was significantly higher, and it was almost 4% in the surgical arm within post of 30 days. The other complications which were significant, it included pneumonia, respiratory insufficiency, arrhythmias, air leakage, cardiac decompression, empyema, and bronchopleural fistula. 8.1% patients underwent reoperation due to positive margins, pneumothorax, empyema, and bronchopleural fistula. Now, we can say that in absence of definitive evidence of any benefit of surgery, chemoradiation or induction chemotherapy followed by chemoradiation should be the standard of care. But there is more to this. Now, after publication of this specific study, we can see that although it was actually planned for unresectable tumors, more than 50% of the patient in both the groups, both in the durvalumab arm and in the placebo group, they were actually stage 3A. And it also showed that durvalumab has better outcome even in stage 3A patients. It had better response, 28.4% versus 16% compared to placebo. In the initial publication of 2017, it showed that durvalumab has better probability of progression-free survival. At that time, it did not reach the median survival. And that holds true even after the final after the 4-year median survival publication, which holds the initial results true for now as well. You can see that at 1 year, at 2 year, at 3 year, and at 4 year, every time durvalumab arm had better outcome compared to the placebo arm. It also holds true for the progression-free survival. And a post-hoc analysis showed that the number of events are actually less in durvalumab arm in stage 3A compared to placebo arm. The toxicities with durvalumab in this study was well tolerated, and they were not significant. Grade 3 and grade 4, if you see, they're quite acceptable and negligible. So when it was seen that durvalumab holds a good role in stage 3A tumor, a detailed analysis was done, and it was published just a few months back. And it says that consistent with the intent to treat population, treatment benefits with durvalumab were confirmed in patients with stage 3A N2 unresectable non-small cell lung cancer. So prospective studies are definitely needed because it was not a properly designed study, but definitely durvalumab shows response in resectable group also. Now, when we compare about the probable side effects of radiation or chemoradiation versus surgery, you can see that there is a significant difference in nature of side effects. So the majority of the side effects associated with chemoradiation are fatigue, nausea, vomiting, esophagitis, pneumonitis, carditis, pericarditis, risk of rib fracture and brachial plexopathy. But practically what we see are fatigue, nausea, vomiting, esophagitis, and pneumonitis. So rib fracture, pericarditis, brachial plexopathy with today's ion radiation technologies, if done properly, are really very less. Compared to that, if you see the risk associated with surgery, there are always risks associated with anesthesia, bleeding, infection, leakage, pneumothorax, thromboembolic events, and volume loss after pneumonectomy. So now the ASCO guideline, which has recently been published, particularly for the stage 3 tumors, it also has given certain recommendation. And if you can see that the role of surgery is applicable only if all the following conditions are met. So only if all the following conditions are met. A complete resection of the primary tumor and involved lymph nodes is deemed possible. So if any one of these two are not possible, then one should not go for surgery. M3 lymph nodes are excluded. Perioperative or 90-day mortality is expected to be very low, which should be less than 5%. And it also says that patients with stage 3 non-small cell lung cancer generally should not be excluded from consideration for surgery by non-surgical physicians, which we radiation oncologists usually believe, and definitely we involve our thoracic surgeon colleagues in decision making. It also recommends that patients with stage 3 non-small cell lung cancer receiving concurrent chemoradiation without disease progression during the initial therapy should be offered consolidation durvalumab for up to 12 months from the Pacific study. So at the end, if we weigh between the risk and benefits, we can see that instead of surgical treatment, a non-surgical approach gives equally good result, if not better, which is essentially non-invasive, less morbid, involving minimum hospitalization, and definitely it involves less mortality risk. So to conclude, I think that stage 3A and 2, it's a heterogeneous group where the role of surgery is very limited and which is applicable for a very few patients. Randomized trials are not available to show any benefit or any additional benefit of surgery over non-surgical treatment modalities. Even in the in the studies where the surgical treatment was compared with non-surgical treatments, the data was not in favor or showing any additional benefit with the surgical arm. Durvalumab is effective in unresectable stage 3 cancer, but it also shows its benefit in stage 3A and 2 and non-N2 groups. Chemoradiation followed by durvalumab should now replace surgical treatment for such patients. I appreciate your patience, and over to you, Dr. Animas.
Thank you, Dodullah. Thank you for your nice presentation. I'll move on to the next debater, which is Dr. Tanzil Janjua. So Tanzil has been my colleague back in my training days in the UK. Very helpful guy. Even during my consultant episode, he was with me. So now he's a consultant clinical oncologist currently working in St. James's University Hospital, Leeds, UK. He is specialized in treating lung cancer and urological cancer. Dr. Janjua has keen interest in image-guided radiotherapy, stereotactic radiotherapy, and systemic therapy for lung cancer. Over to Dr. Janjua. And he will be speaking against the motion.
Thank you very much, Animesh. Just gonna share my slides. Just let me know when you can see them.
Yes, sir, we can see the slides.
Thank you. Thank you very much. Okay. Thank you, animation team, for giving me this opportunity to speak at this meeting, and congratulations on arranging such a fantastic meeting. I think the agenda was superb, and so far it's been great to hear all the speakers. So I'll be talking today regarding the non-surgical treatment with chemo-rad followed by Adjuvant should replace the surgical treatment for resectable stage 3 non-small cell lung cancer, and I'll be talking against the motion. So I'm a clinical oncologist, so always would love to favor radiotherapy and chemotherapy combination treatments. So I think we have to be very careful when we are interpreting any data. We as a scientist, and especially in this era when we are practicing evidence-based medicine, I think it's really important to kind of look at evidence and interpret in a way where we are implementing in its true spirit.
So can I request you to make your slides full screen?
Oh, sorry, it is full screen on my one.
So not at our end, sir. And are you on the first slide, sir?
So I've moved on actually. Sorry, should
Still
I
on the first slide, sir? Oh.
Okay, let me just
So can I
pause
request you to reshare the screen again, sir?
Yeah, okay, I will do that. Are you able to see it now?
Not yet, sir. We can still see the first slide.
Okay, sorry
so
about
with
that.
your permission, sir, can we share the? Now it's moved, sir. Now it's moved to the second slide.
Okay, so maybe I think
so you can reshare your screen again, sir.
I think there's a bit of lag.
Yeah.
So apologies for that. Let me know when you can see them again.
Yes, sir. We can see the screen, sir.
Okay.
Kashish, do you have Tanti's presentation as a backup?
Yes, sir. We have the slide, so we can share it.
Let me know if this works this time. I've moved on to the second slide.
So we still have the first slide, sir. So
please feel free to. I'll stop sharing. Yes, absolutely.
So you can just say next slide, and we'll move to the next slide, sir.
Yeah, sure. So are you sharing it now, or?
Sir, it's already on the screen, sir. I hope
okay.
you can go to Zoom, sir. Yeah.
Yes, great. If you can move to the next slide, please. Yeah, next slide, please. Sorry about that. So essentially, a fantastic talk from Dr. Mundal, and I think most of the evidence that he's touched upon is actually what I'll be talking about as well. So a few important facts. We know that this is a very complex heterogeneous group, so it's difficult when we are discussing these patients in MBT to define what's the right treatment option for them. And the main discussions are about what is resectable and what is not resectable. Another important aspect is to look at these patients upfront is that they carry a high risk of local as well as distant MET. So your strategy should cover both these aspects at the beginning. We know that stage 3 lung cancer is a multimodality treatment with an individualized approach. Next slide, please. We have all talked about this before. There's a clear need to improve the outcomes. We know about 1/3 of our patients with stage 3 disease is 5 years or alive. And just looking at these graphs, I wouldn't go into detail. This has been touched in previous presentations as well, but certainly there's a lot of room to improve there. Next slide, please. Just to give you some visual presentation of what stage 3 means and how heterogeneous it could be. So just look at these slides and see what you would be thinking about regarding these options of surgery and radiotherapy. So you might have a relatively a small sized tumor, but with a single station and node. Next slide, please. You may have multi-station lymph nodes in the same situation. Next slide, please. Or you might end up with a relatively bigger tumor with more nodal volume. Next slide, please. You might have an N3 disease. Next slide, please. And you might have all these features of high-risk disease with multiple nodal station and a very large primary tumor. So just gives you an idea when we talk about heterogeneity, when we talked about an individualized approach, just even looking at how the distribution of the disease could be. It's amazing how much difference that it is in presentation of disease at different stages. And the most important thing here, we've talked about the evidence base. Evidence base is all in resectable disease. So it's very critical to see what was defining this resectable disease. And unfortunately, in this era where we really moved on with very great imaging and pathological staging, we sometimes still struggle to define what is resectable. So this was the paper with Everson and colleagues, which was published in 2019. And can you click the next one, please? So essentially, the two important points that were highlighted in a potentially resectable N2 disease was that they wanted a pathological confirmation of the nodal disease at least 3 nodal stations. We know mediastinoscopy and EBUS are widely used now, and patients were encouraged to have a PET scan as a minimum, MR brain as a starting point. So we get a really good idea of where we're starting from. The primary tumor should have a high probability of clear pathological margins and complete resections, preferably avoiding pneumonectomy. I'll discuss the evidence around that. Again, it's very important for you to try your best to assess with your surgical colleagues and radiology colleagues that this is likely to be a good resection in the end. And easily measurable and defined metastatic N2 disease, lymph nodes should be free from major mediastinal structures, including great vessels and trachea, and size should not be greater than 3 centimeters. Again, trying to define that we have a consistency on how we are looking at these patients up front. Next slide, please. Now, again, my colleague went through this as well. So what we have kind of really got a good consensus in unresectable disease with chemoradiotherapy. We know the chemoradiotherapy is better than sequential approach. We now know that immunotherapy has got fantastic result with the PACIFIC data, though we have to look at this data carefully, and I'll come to that in the end. But it's mainly the resectable disease where we have no consensus. And I think it's a good thing in a way, because we are looking at each individual patient in a different way and trying to work out what's the best approach in them. And let's look at some evidence around that. Can you move on to the next slide, please? So what are the approaches? Number of different approaches. A lot of neoadjuvant and adjuvant data was discussed by my colleague earlier. So a lot of exciting stuff coming. We know that these patients are offered concurrent chemoradiotherapy upfront in surgery. Some patients will be offered treatments in adjuvant setting, which chemotherapy we commonly use with or without radiotherapy. Then we have used neoadjuvant chemo alone, followed by surgery with or without radiotherapy. And we've discussed the PACIFIC data, but also we have used chemoradiotherapy in resectable disease as well. So just need to look at what's the role of IO and targeted therapies, given that we are in the time where everything is evolving so quickly. So just move on to the next slide, please. So looking at the major guidelines that we follow, NICE came up with it in 2019 with this guidance that we should consider chemoradiotherapy upfront in neoadjuvant setting in N2 disease, which is really interesting. And I'll talk about the evidence in that. I must say this is not something we practice in the UK. There is trend towards it, but this is not something we are all practicing in this setting. So there is a lot of variation. ASMO says there's no recommendation can yet be made, and MDT to decide on multimodality strategy. And the NCCN more or less takes the same approach, but again, just highlighting the fact that radiotherapy and induction regime hasn't really shown a lot of survival benefit and long-term outcomes. Next slide, please. So the NICE did a meta-analysis looking at 10 randomized control studies, which looked at a multimodality treatment in neoadjuvant setting, mainly chemoradiotherapy versus surgery, or chemo alone in neoadjuvant setting versus surgery alone. So they had these 3 arms, and the outcome they came up with, that's mainly they said it's quite cost-effective thing if we can give chemoradiotherapy upfront with a good outcome. They did see some better progression-free survival, and there was some trend towards better overall survivals, but nothing really significant. But the downside of all this trial was that there's a large heterogeneity in the trials. None of the trials individually showed there was survival benefit. So you can argue why you're seeing the trend. And this didn't include any immunotherapy studies. Next, please. So looking at neoadjuvant chemoradiotherapy and surgery in this setting, very difficult to recruit. We've talked about that in Saber setting as well, but anywhere we are trying to compare these modalities. These are not easy studies to conduct. The two modern day studies that I want to talk about is the Albion study, which was published in 2019. Again, they looked at specific N2 group. They had induction chemoradiotherapy with cisplatin-based chemotherapy and had up to 45 gray, followed by randomization to surgery at 4 to 6 weeks, or they went on to have up to 61 gray chemo-rad. Next slide, please. So if you look at the outcomes, unfortunately, there was no real survival benefit seen. The results didn't prove one treatment to be better than another. It was quite decent sample size of 396 patients. There was some improvement seen in progression-free survival in the surgical arm, but unfortunately, there was quite high morbidity with actually mortality of around 8% in patients who had pneumonectomy. So that kind of pushed people to try to avoid pneumonectomy and go for lobectomy as a plan up front. Next slide, please. The Epsuit study was another phase 2 study. It's a quite interesting study design. If you move to the next slide, please, that might be easier to look at the pictorial form. Next slide, please. So sorry about this busy slide, but essentially patients were offered induction chemo upfront, followed by chemoradiotherapy, and then they were randomized to chemoradiotherapy or surgical arm. So quite an intense treatment regime. Next slide, please. Again, it didn't show any difference in both the modalities in overall survival or progression-free survival. Very good median follow-up of 78 months. But what this trial did show that overall the 5-year survival was very impressive of 34%. So they actually showed that both these modalities were quite good in controlling the disease. Can you move forward, please? So just looking at these Kaplan-Meier curves, so again, not much difference, but good outcomes eventually in both arms. Next slide, please. Then we've got this another SAC16/00 study, which looked at neoadjuvant chemo RT versus neoadjuvant chemo alone. Patients again had resectable disease. They either had 3 cycles of chemotherapy in neoadjuvant setting, or they had 3 cycles of chemotherapy followed by sequential radiotherapy. Now, if you look at the R0 resection, it was actually better in sequential radiotherapy. Can you move forward, please? But again, there was no real difference in the survival outcomes. Next slide, please. What the trial concluded was the RT was active in neoadjuvant setting. There was response, better complete resection PCR rates. However, it's not really translating into long-term disease control or survival outcomes. What this study did show that actually pneumonectomy was actually a safe procedure to do, which was interesting given what we previously saw. Next slide, please. Now, just looking at the meta-analysis, I think my colleague already touched on that systemic review and meta-analysis of 6 trials, which looked at neoadjuvant chemo alone in 4 trials and induction chemo-rad in 2 of these studies. And again, it didn't show any difference in both the approaches. Next slide, please. So again, just touching on the evidence around what we've got in adjuvant setting, because it's important when we are offering patients any modality, either surgery or radiotherapy upfront, we know what are the likely options after that intervention. And we know from the lung art study that patients who had N2 disease, bear in mind this was a group of patients with R0 resections, they didn't had any significant disease-free survival outcomes at 3 years. But what it did show was that these patients who were offered radiotherapy did have increased cardiopulmonary toxicity, which can be life-threatening. So the grade 3 toxicity was significantly more than in people who had post-operative radiotherapy. So it's another important consideration in planning the treatments. Next slide, please. Our colleague has already gone into details of adjuvant and neoadjuvant data that and treatment options we have got available. We all know the LACE study with 5-year overall survival. Again, we know the main benefit comes from high-risk groups. So again, one important option there. Next slide, please.
So 2 minutes left, sir.
Sure, thank you. Next slide, please. Adjuvant Aussie data is being discussed. So I know this is, we are waiting for survival outcomes in the long term, but very promising data with a hazard ratio of 0.17. Again, had 3A disease patients in there. Next slide, please. Adjuvant immunotherapy after surgery, again, very exciting times for us. There's 6 phase 3 clinical trials being evaluated, looking at monoimmunotherapy. Next slide, please. So just to show you that, look at these phase 3 trials on the left. And if you look at the study end, trials are hopefully be completing their, this will be completed in the next few years. So we will have a very robust data of immunotherapy outcomes in hopefully next few years. Next slide, please. We've already talked about Empower 010 study earlier in the UK. We have now got CDF approval for atezolizumab in patients with more than 50% PD-L1 expression in stage 2 and 3A. So again, another very good option. Next slide, please. The Neoadjuvant Strategies with Immunotherapy, Checkmate 159 study. It's a phase 1 study with a promising results. Next slide, please. Sorry, I'll have to rush through the slides with time issues now. Next slide, please. If you move on to the next slide, it was a good summary, so I'll probably just skip this slide in the interest of time. A NEDIM study has been talked about earlier, very impressive data, actually. Next one, please. The NEDIM studies looked at Nivo with combination platinum-based chemotherapy with excellent results. Can you move to the next slide, please? And the major pathological response of 83%. So again, this is a very important study looking at combination chemo IO. Next slide, please. So the other interesting thing was there was no increase in immune-mediated toxicity in this combined setting, which is, I think, is very, very reassuring. And the major side effects in grade 3 and 4 setting was hematological. Obviously, this needs a phase 3 confirmation study before we can implement into clinical practice. Next slide, please. Next slide, please. Again, in this setting, we've got phase 1 and 2 studies in neoadjuvant setting. You can actually move forward. I think I can skip these slides. We are now looking at neoadjuvant radiotherapy and IO combinations. If you move on the next slide, please. Just wanted to show you this. This is interesting because with radiotherapy and immunotherapy combination, we are always a bit apprehensive in terms of toxicity. And these are all phase 1, phase 2 studies, but they are looking at combining these two modalities in concurrent setting. And so far, we haven't really heard from any of these trials. It's too early to say maybe, but there's no real concern that has come out when they've combined these modalities, which I think is really encouraging. Next slide, please. Just couple of quick words with Pacific study. I think we're all very excited, and clearly it's a very impressive data. But just to point these things that this data has got very fit patient cohort, which I'm not really sure our true lung real world patients are. The data doesn't really tell you what we did with chemoradiotherapy setting. What were the radiotherapy volumes? What were the techniques? What were the OAR doses? This trial was randomized post-chemo-rad. You don't really know how many patients actually ended up going into randomization. We know that following chemo-rad, they can only go in on IO if they were still PS1 and they didn't have a grade 2 toxicity. So I think there are a lot of important things to actually consider rather than just following it blindly. It's still very impressive data, but just a bit of caution there. And we're still learning about the optimal duration of IO and timing of IO-RT. Next slide, please. So I'll just conclude to say that this is a very heterogeneous group. We have got different potential approaches with good outcomes. So surgery is indicated in some and not, but certainly it's a multimodality approach, and patients shouldn't be denied surgery based on the evidence that we have got if they are deemed eligible and if they want it. We'll soon see IO coming around perioperative setting, probably will influence the results in decision-making. And non-surgical treatment remains an option, but no evidence to support that you should replace surgery in resectable patients in stage 3. We shouldn't follow a blanket approach based on a trial which was not done in the setting which we were talking about. Thank you. Apologies for the issues with the IT.
Thank you, Tanzil. Thank you for your nice presentation. Can we have a quick rebuttal from Dr. Dodul Mondol? If you've got any, just some quick comments.
Excellent presentation, Dr. Janjua, and I think yes, we should not fight. Although it's a debate, I understand, but yes, we have to accept that there are a lot of flaws in this stage 3 resectable lung cancer. The very definition of resectable lung cancer, stage 3 lung cancer, is very much questionable. So till the time there is a proper definition of what is resectable, yes, we have to ultimately depend on the MDT decision. And my contention is to make one thing very clear, that it's very sad to see that many times, even in MDT discussion, the role of chemoradiation is being ignored, and that should not. That perhaps we definitely should discuss about the significant role of chemoradiation in this setting, rather than blindly going for surgery also.
Thank you. Any final comments? Any rebuttal from Dr. Tanzil?
Absolutely agree what my colleague has said. I think there is no one blanket approach. Chemoradiotherapy is a very effective treatment modality. This is a complex group of patients. So I totally agree with him. We should assess patient on an individual basis and consider all treatment options, keeping in mind the neoadjuvant and adjuvant options coming through. So yeah, I totally agree with him.
I think we have to conclude this session here. Thank you both. We'll move on to our next session. So our next session is a debate. The topic is proton beam radiotherapy is not better than photon radiotherapy in locally advanced lung cancer. And to speak for the motion, we've got Dr. Ahmed Salim. So he was in Christie as a consultant clinical oncologist, but I heard he recently moved to Jordan. So as you all know, Christie is the first center in UK to got proton beam radiotherapy. So Dr. Ahmed Salam is a consultant clinical oncologist at Afia Radiotherapy Center, Amman, Jordan, assistant professor in Hashemite University in Jordan, and an honorary senior clinical lecturer in Manchester University, UK. So over to you, Dr. Salam.
Hello. Yeah. I hope you can hear me fine.
Yes, you can.
Okay. So thank you very much, Animesh, for inviting me. It's a pleasure to be part of this informative meeting. And yes, I was in the Christie till very recently, and I actually led the efforts to treat the first patient. So that should hopefully give more credence to my debate here. So these are the topics that I will address. So first, I'll go over the medical evidence on the role of protons in lung cancer. Then I will address why I think the routine use of protons before a clinical trial is actually published showing their usefulness could potentially be detrimental to our patient group. And lastly, I will address why it is actually not practical to use protons in lung cancer in the current treatment landscape. But first, I think it's wise to do a quick introduction. So we've heard this today. We know that lung cancer is the leading cause of death worldwide, and it is indeed a significant economical burden. We also know that non-small cell lung cancer is the most common lung cancer subtype, and that patients who have stage 3 disease constitute around 20% of these cases. And I agree with the previous speaker. There is no question in my mind that there is a significant unmet need when it comes to improving the outcomes in this patient group. However, I think we need to be very mindful that there is currently no medical evidence to support the use of protons in lung cancer. And I think my respected debater will probably show you that these results and will try to make arguments why this was indeed a negative trial. So this is an important study that included patients with a stage 2, 3, and also selected oligometastatic stage 4 patients. These patients were treated with concurrent chemoradiotherapy, and they were randomized only if they had met pre-specified dose parameters to either state-of-the-art photon technique, so IMRT, or a passive scattering a proton approach. And I suspect my debater will probably comment on this and say that this is considered an outdated proton technique, and I would agree with that. But please note that both the co-primary endpoints were negative for this trial. So grade 3 or higher radiation pneumonitis or local failure were indeed similar between the two groups. And you can see this clearly in the curves here. So I would say, so no matter what you hear, this was a negative trial. And anything apart from that is indeed a fake news. I'd probably agree that, yes, the authors have reported a lower splash dose to the heart and lung, and this particularly pertains to both low and medium splash dose. And also, they reported that both of the endpoints had improved over the course of the trial. So patients who were recruited after the study midpoint had better outcomes when it comes to these endpoints than before. And this obviously showcases a possible learning curve. So I think we can conclude using this trial that outdated proton, so passive scattering proton technique, is definitely not better than state-of-the-art photon approaches using IMRT. But what about intensity modulated proton therapy? So what about the state-of-the-art proton techniques? Well, this retrospective study addressed the use of a proton spot scanning in lung cancer patients. It involved 64 stage 3 non-small cell lung cancer, nearly half of which were treated with spot scanning protons, and the other half received intensity modulated photon radiotherapy. And again, similar to the previous prospective trial that I had just presented, the authors did not see any statistically significant differences with regards to toxicity, overall survival, and progression-free survival. And you can see this clearly with the Kaplan-Meier curves, which are overlapping. So again, this is a negative study. And what is nice, I would say, about that particular retrospective cohort is the fact that they have reported on hematological toxicity. So we know that this is important because severe reduction in lymphocyte count or lymphopenia, we know that this is now an established poor prognosticator in lung cancer patients. We also know that lymphopenia occurs quite commonly in non-small cell lung cancer patients treated with chemoradiotherapy. And this seems to be related to an increase in dose to central thoracic structure. And you can see this area here. And while we know that protons, at least from a previous retrospective study, seem to be able to reduce lymphopenia in an esophageal cancer dataset, this was not the case in the retrospective study that I presented. And here, what the authors reported was that both the neutrophil and the white blood cell counts were not dissimilar, so were the same between the two groups, albeit that they did not specifically look at the lymphocyte count because they did not have that data. But you would assume if neutrophil count and white blood cell counts are not dissimilar, so they're the same, you would assume that probably lymphocyte counts were also the same. So if we go back to the first question, I would say the answer to it is that we currently do not have any medical evidence to support the use of protons in lung cancer. And I would say definitely we do not have any level 1 evidence. And actually, up until today, the results have been fairly disappointing. And while my debater will probably argue that there is dosimetric advantages, which have been reported in previous studies, they have not actually translated into any clinical advantage. And we really need to await the results of the ongoing randomized Proton versus Photon trial and its relevant endpoints, namely survival, cardiac toxicity, and lymphocyte reduction. So now I'll move to the next topic, and specifically whether there is a possibility of causing a harm from the use of protons. And here I'll touch upon two main topics. The first is the uncertainty relating to the relative biological effectiveness of protons, and then the learning curve, which I have previously talked about briefly in the previous trial. We now know from big data analysis that there is evidence pointing towards a relationship between increased radiotherapy dose to certain cardiac substructures, particularly at the base of the heart, and you can see this here, with an increased risk of cardiac adverse events, which lead to heart attacks and premature death. And unlike breast cancer, in lung cancer, this seems to occur quite early on after treatment, with early separation of the curve as early as 6 months. We also know from the reported American trial, which I had shown earlier, that protons are able to reduce the mean heart dose compared to photon techniques. And we have indeed confirmed this with a small planning study that we did in Manchester with the help of UCL, but we saw two crucial findings, I would say, which are important to note. First is that this preferential ability of protons to reduce mean heart dose seems to be reliant on the location of the tumor relative to where you want to spare. So definitely if you have overlap between the GTV and these sensitive cardiac substructures, which tends to occur whenever you have mediastinal nodes, you will not be able to spare these sensitive cardiac substructures. And the second thing that we noted is that there was no difference in the maximum dose, IMPT versus IMRT. And if you look at the previous big data analysis, these seem to show that the maximum dose rather than the mean dose is actually important and detrimental to outcome in these patients. What about the biological effects of protons, particularly at the distal end of the Bragg peak? So this is an example of the first case that we treated with protons in Manchester. And I think this is a case where it seems reasonable to treat with protons adenoid cystic carcinoma in a relatively young lady, which is expected to live long. And obviously with protons, you can reduce the dose to the breast as well as the lung and potentially to the heart. However, there is a problem with this Bragg peak, and indeed there could be increased toxicities associated with that distal end of the Bragg peak because of the uncertainty of the RBEs there. So we know that the RBE uncertainty could be anywhere between 0.7 and 1.6. And from this seminal paper, which was published quite a while ago, but still it seems relevant, this has actually highlighted that the local hot region could lead to additional biological effects more than what we see on dosimetry, and that these need to be considered, particularly when that hot area overlaps with critical organs. And like I said, this is usually the case for stage 3 non-small cell lung cancer. The second issue is the learning curve. And I think there is no question in my mind, having already treated patients using protons in the lung, that a lot of caution needs to be exercised when treating these patients. And this is what we saw in Manchester ourselves. And we have also seen this in the previous trial, which showed that the incidence of radiation pneumonitis reduced over time. So you can see this with the yellow curves, showing that this is particularly true when implementing new techniques such as Proton. And I think this applies for both passive scattering and definitely for IMPT approaches. So I would say for the second question, I think it is possible to cause harm from the routine use of protons before a clinical trial is shown to be positive. And I would say the main reasons are the uncertainty of RBE and the potential learning curve. The third question is about practicality. Can we actually treat patients with lung cancer using protons? And at least if you use the British model, the NHS proton centers currently only have very limited capacity when it comes to treating patients. So that's less than 1.5% of the total radiotherapy capacity. And if you couple this with the high incidence of lung cancer, particularly stage 3, I don't think we have the capacity to treat all stage 3 non-small cell lung cancer patients with protons. And I would say we don't have a validated normal tissue complication probability model that we can use to select patients, because all of these have been developed using photon data, which might not necessarily be valid within the proton environment. And again, from a health economical standpoint, proton radiotherapy is probably at least 8 times more expensive than photons. And again, this is data from the UK model. So you would definitely need trial results to justify their use.
2 minutes left, sir.
Thank you. So in the end, this is my final slide. I would say that proton radiotherapy currently is not better than photon radiotherapy in locally advanced lung cancer, because there is no level 1 evidence supporting it. We need to await the results of ongoing trials. And obviously there's many uncertainties relating to their use, namely the learning curve and the RBE. And lastly, the impracticality and impossibility from a health economic standpoint to treat all locally advanced lung cancer patients currently with proton radiotherapy. Thank you.
Thank you, Dr. Salem, for your excellent presentation. I'll move on to our next debater, Dr. Srinivas Chilikuri. Dr. Chilikuri will be speaking against the motion. He is a senior radiation oncologist currently working in Apollo Proton Cancer Center, Chennai. So as you all know, Apollo Chennai is the first center in India to get a proton beam radiotherapy, and he is credited with initiating South Asia and India's first clinical program for particle beam therapy for pediatric cancers, prostate cancer, thoracic cancers, and sarcomas. He is the co-founder and currently the chairman of Optimus Oncology, which has been working towards the modern cancer care to the rural pockets of India. Over to you, Dr. Chilikuri.
Thank you, Dr. Animesh. Thank you for this opportunity. You can hear me and see my slides, I hope.
Yes, we can. Yes, we can.
Great. That was an excellent presentation by my colleague, Dr. Salem. I congratulate. But of course, I would like to argue that there is a role for proton in locally advanced lung cancers. If I have to summarize why do we need to look for better options than what we have right now, is that there are many challenges for the thoracic radiation oncologist. Typically, if you go by the eligibility criteria as per the major randomized controlled trials for chemoradiation, which is the current standard, age less than 75, PS at least 2, weight loss less than 10% in last 3 months, FEV1 less than 40% of age predicted value, and adequate cardiac, renal, hematological functions. Even in a Swiss setting, what this study elegantly showed that nearly 1/3 of patients less than 60 were not eligible for concurrent chemoradiation. 50% of the patients were not eligible for concurrent chemoradiation between 60 and 70. Between 70 to 75, almost 60%, large majority did not qualify for concurrent chemoradiation, and almost as it defined less than 75. So every patient more than 75 years is not eligible for concurrent chemoradiation. This was in the Swiss setting. I can't even fathom to imagine what would be if we do the similar study in a setting like India. And in very few sites in human body, the acute dose limiting toxicities actually determine overall survival. The esophagitis is known to, has been shown in RTOG 0617 to have an impact on overall survival. The volume of PTV, the heart V5, the location of the tumor, all these have been shown to be an important determinant of overall survival. We have subacute radiation pneumonitis. Of course, we have a group of patients who are more prone to that particular complication, but we've seen grade 3 radiation pneumonitis in about 5 to 10% across all studies, with 2% of them being even fatal. Cardiovascular toxicity, Dr. Salem actually mentioned very well that the median time to develop these toxicities is not beyond the lifespan of a lung cancer patient. In fact, it starts within 6 months, and you see complications actually within a year. And there is tremendous evidence to suggest that there is a large chunk of patients who do have cardiovascular complications, arrhythmias, ECG changes, and so on and so forth. And these also have been correlated with overall survival. We've already learned a little bit from the postoperative lung trial, which was published recently, that there is a large percentage of patients, again, who die of cardiopulmonary causes in this randomized trial, and grade 3-4 cardiopulmonary toxicities also were significantly large in patients who received, of course, this was 3D conformal radiation therapy in a great majority of the patients. We know what are the group of patients who where the cardiac doses could be significantly high. These could be patients who have subcarinal nodes or multinodal station involvement, or even contralateral hilar nodes, which actually increase the dose to the heart. And do we have a constraint to the heart? Do we know, is it the mean heart dose? Is it the pulmonary artery dose, as RTOG 0617 in the modeling study showed the base of the heart? Is it, what is the structure? What is the cardiac substructure which can be taken as a surrogate for toxicity? We are still evolving. We are still learning. And what are the cutoffs? We are still evolving, and we still don't know. And the best thing to spare as much as possible and as far as possible. Despite all these, we have underwhelming clinical outcomes. We know that a large majority of the patients have local failure, 40% regional failure, large distant failures. 2-year PFS was 30%. Of course, in the immunotherapy era, the 2-year PFS has improved from 30% to 50%. As the previous speakers have pointed out, there are limitations, and if you want to extrapolate specific trial into our setting, where it's sometimes unrealistic to expect that kind of patient population in day-to-day practice. Dr. Salem also mentioned about the lymphopenia which happens, and there is a correlation between lymphopenia and the outcomes in this systematic review and meta-analysis. Although Dr. Salem chose to show a very selective study of only 60 patients and treated that to 30 patients with protons, and based entire argument against proton therapy on the basis of that retrospective study, I wouldn't agree with him. And there are a number of studies across sites, not just in lung cancer, esophageal cancers, which he mentioned. And there are many other sites which have clearly shown that lymphopenia seems to be definitely lesser in patients receiving proton beam therapy, essentially because physical advantages of proton therapy. We all are aware of the physical advantage of proton therapy in terms of the Bragg peak. How is it different from the X-rays? The radiobiological uncertainty, of course, in a way, radiobiological uncertainty, if you use it you could use that as a strength. If you use multiple beams to avoid uncertainties, you could potentially use it. And there are ways to predict the LET, and LET based optimizations are very soon going to be a reality and going to be in the clinic. Already they are available as research modules on our commercially available treatment planning systems. And LET seems to be a reasonable surrogate for RBE, and it can be used And if you use the RBE, higher RBE to our strength, it could be even a potential advantage. I mean, evidence apart, I mean, this patient came to us almost 2 years back, 63-year-old gentleman with squamous cell carcinoma, T3, N3, lung cancer, diabetic, hypertensive, weight 120 kgs. He has obstructive sleep apnea, occasionally on oxygen, and the PET showed N3 node, because of which a patient was deemed unresectable. Apart from all the comorbids he had, the radiation oncologist in Mumbai ran an IMRT plan in breath hold, and he saw that the V20 was 36%, V5 was more than 60. Mean heart dose was 30 gray. He was not comfortable, so he sent the patient to induction chemotherapy. I wanted to reassess after a while, and nothing much changed, unfortunately. And when the patient came to us, we planned with the breath hold. Even though the patient was on oxygen, was able to hold breath comfortably for more than 20-25 seconds, and we could treat this patient under breath hold with proton beam therapy. And you can see that the mean heart dose came down from 30 gray to 7.2 gray, 20 gray mean dose to 12 gray, V20 36% to 22%, V5 more than 60% to 35.5%, thereby reducing significantly the probability of grade 3+ toxicity. This patient continues to be on follow-up, and this is March 2022. There are some post-radiation changes. But the PET is clear, and the patient is asymptomatic, relatively asymptomatic, and is doing very well, and is on follow-up after nearly 2 years after proton beam therapy. This case is not an exception. There are now multiple dosimetric studies. Of course, these are small retrospective studies which have shown, and even single institution prospective studies which have been published, which have shown dosimetric superiority of proton beams, showing varying, in fact, not just dosimetric superiority, but reducing the rates of severe pneumonitis, esophagitis in various small series. You can see the number of patients, about 62 protons, 134, 14, 64. So small retrospective studies, some phase 2 prospective studies as well, clearly showing that there seems to be reasonably good toxicity. So the harms which Dr. Salim emphasized are probably unfounded. Of course, there is a need for adaptive treatments. For this gentleman, we had to adapt treatment. This was the initial scan. This was the first week. Within 3 days, we saw a scan, and the CBCT picked up this slight increase in the size of the lesion within 3-4 days, and that caused significant dose perturbation, and we had to adaptively replan this patient. There is some underdose you can see here, as well as near the nodal region, and we had to plan, in fact, twice we had to plan in this patient on basis of adaptive replanning. We now know that IMPT seems to be significantly better than passive scattering. This is again another retrospective study, 139 patients. 62% received the older generation passive scattering proton therapy, 38% IMPT, with a median follow-up of close to 2.5 years. Grade 3 toxicities were higher in passive scattering. Grade 3 pulmonary toxicities were higher in passive scattering. Overall survival, of course, we will not go into overall survival, but clearly the toxicity of passive scattering seems to be much higher. The survival seems to be figuratively higher, but as I said, this is not statistically significant because this is a small patient study. National Cancer Database study again showed similar results. We know all the limitations of such analysis. Despite that, clearly proton beam therapy seems to have slightly better outcomes compared to conventional radiation therapy techniques in propensity matched to balance all the covariates in both in stage 2, stage 3 lung cancers. Of course, the cost effectiveness, I do agree with Dr. Salim. It is probably not yet cost effective, but there are some studies, at least in United States setting, such as this, which actually showed that proton beam therapy seems to have a promising cost effectiveness for a very few selected sites, including that in loco-regionally advanced non-small cell lung cancers. And we come back to the randomized trial, which Dr. Salem showed. Yes, it was a Bayesian adaptive. I have no complaints regarding the design of the study in general. But of course, if it is done well, Bayesian could be a good pragmatic approach to test a hypothesis, specifically in proton beam therapy in proton field. But nevertheless, the fact is that patients who were randomized to protons did not receive protons. Patients who, in fact, a significant chunk, nearly 25% of patients were, patients who received either proton or photons, where the protons were the only acceptable plan on dosimetry. And of course, the biggest fallacy, issue with my issue with the trial is the passive scattering proton beam therapy, large safety margins used. I think these are older techniques which have been used, and I don't seem that they are relevant. Dr. Salem also mentioned that the primary endpoint was negative, although it showed that the hard doses were lower, which is absolutely right. And what he also showed that there was a clear learning curve with protons. And I think this everyone should understand that in the first half of the study, radiation pneumonitis being the primary endpoint, I think this is an important point.
So 2 minutes left, sir.
Yeah, in the first half of study, 25% had pneumonitis, whereas in the second half, almost none had pneumonitis. And my problem with this study it is passive scattering. It is not the standard of care right now. There is a clear learning curve. RCT should be started after establishing a technique. It used pencil beam algorithm instead of Monte Carlo. We know the limitations of pencil beam class B algorithms, less frequent adaptive planning, large PTV volumes, and the design of the study itself are the key fallacies. And I think RTOG 1308, as well as another study from North America, probably will enlighten us in more regarding proton beam therapy. And there are multiple phase 1 and phase 2 trials ongoing, testing proton therapy. I think there is enough equipoise at least to do a randomized control trial. And of course, motion is an issue. We do have our own protocols. We use multiple fields, not just 2 or 3 fields, especially in lung. We do 4D robust evaluations. There are ways and means to overcome some of the RB uncertainties, which Dr. Saleh mentioned. And we had initially presented initial 20 patients last year at ISTRO in this study. And to conclude, proton therapy seems to have a potential in reducing toxicities, esophagitis, and cardiopulmonary toxicities. There are several theoretical advantages, immunological, higher radiobiological effects, with and without immunotherapy, the potential for safe treatment intensification with dose escalation, with hypofractionation and concurrent chemotherapy should be explored. And we have shown, I think actually I've skipped the slide, that there is a scope for hypofractionation with concurrent chemotherapy with protons. RCT evidence is required, there is no doubt about it, and hopefully it will emerge in the definitive setting. It seems to be very promising in post-operative setting. We have treated a few patients of post-operative lung cancers to very, very gratifying results. Recurrent setting is also something which has been published before. If you are reading a trial on protons for lung cancers, you must see that if it is not having IMPT, not having image guidance, Monte Carlo, motion managed, adaptive treatments, then I think it is not relevant as of today, because this is an older generation technology and that should not be used for any comparison. Of course, the cost and access remain the major challenge. Hopefully with smaller and smaller footprints of proton beams, these challenges can be overcome in the future. With this, I would like to conclude and thank the organizers for giving me this opportunity.
Thank you, Dr. Chillikuri, for your excellent talk. May I have some rebuttal comments from Dr. Salem?
Yes, so again, thank you very much for the very nice debate. I would say a couple of comments. First of all, I fully agree with you that LET optimization is something that we need to consider going forward. I would say the dosimetric superiority that you've shown is nice on the plans, but we never know for certain what it means. And we have previously been surprised by the results of RTOG 0617, and it might be that the dosimetric advantages of protons that we see on the planning system might surprise us as to the biological effects that they actually cause. The case that you presented, I would say, might make maybe a good use of protons, but if this patient was presented to me, I'd probably just consent them for an increased risk of lung toxicity and treat them using standard of care photon approaches. And then finally, the final two messages and points are about the NC National Cancer Database that you've presented. So just bear this in mind that yes, it had protons showing superior outcomes compared to photons, but it only included a very small number of proton patients, so around 300 compared to, I think, 20,000 patients treated with photons. And finally, practicality. You touched a very important point about adaptation of treatment, which I did not actually address. And I have to be very honest with you, proton treatments in lung are very complex. And, with the patient that we treated in Manchester, a lot of adaptation is necessary, usually like 1 or 2 adaptive scans. And I think coupled with the lack of availability of proton centers and the cost, adaptation just is a pain in the neck. And I think makes it very difficult to implement this routinely currently. But thank you very much again for all of your nice debate points.
So, Dr. Chilikuri, any comments?
Yes, I would agree that proton therapy I would not recommend as a blanket treatment for all locally advanced lung cancer patients. There's no doubt about it. But I was not very happy to hear Dr. Salem when he mentioned that he wouldn't refer that patient. I mean, there was a clear advantage of protons. So I would say that protons, depending on the location, depending on the PTV volumes, some should be considered for protons. Of course, for those who have access and are able to go to a proton center, of course. But there is, as far as science is concerned, there seems to be a huge potential definitely in certain percentage of patients. It could be 15%, it could be 20%, it could be 25% of locally advanced lung cancers. But I think there is a potential for benefit. And I think randomized trials, again, will get it wrong in the sense, because if you randomize all patients, all comers in upper lobe, lower lobe, central lesions and small PTVs, probably you will not get the right answer. But nevertheless, there will always be patients who would really benefit with protons, and agreed that radiobiological effects are uncertain in protons to an extent. But as I said, there are means to mitigate or minimize those effects, and dosimetry is the biggest surrogate we have in radiation oncology. And I agree that protons dosimetry doesn't reflect always what we see on the planning system, but to a large extent it does. I mean, if you spare the majority of the lung, you would definitely, if you're not irradiating any part of the lung on the contralateral side, you would definitely not see any radiological effects on that lung. So I believe that there is a role for proton therapy in locally advanced lung cancers, and it is here to stay.
I've got a question to both of you. So for ILD patient, particularly with the fibrotic changes, you are always concerned about risk of pneumonitis. Sometimes it is considered as a contraindication for photon radiotherapy. So any experience of treating ILD patient, maybe non-fibrotic or fibrotic patient with treating proton therapy?
Yeah, I have treated 2 or 3 patients. Of course, the third patient is a very mild case of ILD, but 2 patients we have treated, not for locally advanced lung cancer, though. Patients have been of stage 1 lung cancers. In the setting of COVID, the lung was extremely unhealthy in the background of ILD and COVID. And a few suspicious nodes, which of course were biopsied, and both very gratifying results. We could treat them safely. I don't have a comparative study to tell you, but very small experience so far, last 3 years. So I mean, it can be done. Proton can be used in some patients, if not all patients.
Dr. Salem, any experience with that?
Yeah, so I think that's a very important point. I think that makes a very good case for the use of protons. In my eyes, even, I don't think you need a randomized study to show this, because I think there is no equipoise. These patients tend to have very poor outcomes with standard photon approaches. If you can reduce the dose to the lung, which you can definitely do with protons, I think in my eyes, yes, these patients need to be treated with protons, even stage 1 disease. So I would probably I think there's a stronger argument for stage 1 because they can live longer. The biggest problem I think that you're going to get is from the regulators and, you know, the people who reimburse protons there, because they might say, okay, well, these patients do very badly anyway, why would we do that? But I think that makes a very strong case for protons in my viewpoint.
Okay, thank you. I think we have to conclude our session here. We'll move on to our next session. Our next speaker is Dr. Sushil Agarwal, and he will be talking about the role of pulmonologist in palliation of lung cancer. Dr. Sushil Agarwal is a senior consultant pulmonologist currently working in Apollo, Kolkata. He has been trained in UK and was working as a consultant in Glenflint Hospital, University of Leicester, NHS Trust UK. Dr. Agarwal has got keen interest in thoracic oncology and thoracic intervention. Over to Dr. Agarwal.
Thanks, Animesh. Can you hear me?
Yes, we
Hello?
can.
Yeah, thanks, Animesh, for a kind introduction and inviting me for the talk here. Let me share my slides. I don't know whether it's oh, yes, thank you. So I think when you gave me this topic of role of pulmonologist in palliation of lung cancer, it came to my mind that palliation starts even at the time of diagnosis and sometime before that, before we know that we are dealing with the lung cancer. And with the different structure in different parts of the world, palliative care consultants are not always available, though we rely a lot on them. But palliative care in lung cancer starts, and I think is everybody's responsibility. So I kept my talk mainly towards endobronchial interventions, pleural intervention, and some other common issues which we come across in the patients of lung cancer. Next slide, please. So as I said, sometimes we even don't know whether we are dealing with lung cancer, because almost 1/3 of our cases come through emergency and with acute presentation. And unfortunately, they have poorer performance status and they do worse. Their associated comorbidities and other conditions make them difficult to treat in the terms of curative treatment. So we need a both plan of a diagnostic strategy as well as treatment plan in that cases. Next slide, please. So just to, this is very common for all of us. Men in 60s comes with a hemoptysis, history of blood, not getting better with the course of antibiotics, on and off cough for few months or few years, and has a strong smoking history. Next slide, please. And when you do an X-ray for this patient, you find an abnormality. You can see a right hilar abnormality with atelectasis at left hilar abnormality with atelectasis at left upper lobe, which we can confirm on CT scan. Next slide, please. And here we can see that it's not only the mass at the hilum, but it's endobronchial growth in the trachea, and it's compromising the tracheal lumen quite significantly. And these are the cases where you need to intervene soon, because you are at risk of losing the airways, and it's one of the major airways which are at a risk. Next slide, please. which we can see on the parenchymal window as well. Next slide, please. So then it comes to our main discussion, which endobronchial intervention, particularly in the background of endobronchial obstruction. And with any large airway involvement, this patient need to be monitored very closely, both in their clinical, with their clinical symptoms as well as their radiological appearance, and need to be offered treatment pretty soon. Endobronchial intervention with or without stenting and can be done, and some of the cases they do respond. I'm talking in front of mainly oncologists, but I think they do respond to radiotherapy. But before that, sometimes we do not know even the histology for these patients. When we deal with these patients, there should be a distal lumen where it can open to. So, for example, if you are dealing with the obstruction of the right upper lobe, if there's a complete atelectasis and there is nothing to go into, there's no point in debulking or trying to salvage that airway. So also that all cancer service should have access for intervention and endobronchial treatment in these cases. Next slide, please. So what we can do for these cases, we can do debulking by various means, by laser, electrocautery, stenting, which has a more immediate effect. And sometimes these are not very commonly done because of probably the delayed effect and not easy availability, but brachytherapy and photodynamic therapy can be considered in these cases along with the cryoablation. Next slide, please. So when we talk about how to deal with these endobronchial tumors or endobronchial obstruction, we deal with hot techniques or cold techniques. The common ones are electrocautery, argon plasma coagulation, and laser treatment. Next slide, please. So with the electrocautery, which is more easily available and cheaper, you can pass the heat waves with the electricity and can cause tissue destruction, and along with the destruction of tissue, opening the lumen, it can achieve a good hemostasis. But we have to be careful with the depth of penetration. Not that difficult to train, but cannot be done in patients with pacemaker or extraluminal lesions. Next slide, please. And similar way, APC, which is also quite commonly available, can be used by passing ionized argon gas, and it can achieve a good hemostasis and can open the airways. But the availability and the expertise can be sometimes a limiting factor. Next slide, please. Laser is much more expensive, but has better results in most of these cases. And it can you can apply the laser waves parallel to the bronchial axis, and these can cause destruction of the tumor and open the lumen. In all these cases, we have to be careful because the risk of fire, and with any of these, and anyone with a high oxygen requirement, we might not be able to offer this kind of treatment. Thank you. Next slide, please. But with the cold techniques, we can use carbon dioxide or nitrous oxide to cause freezing of the tumor, and this can be removed. However, there can be risk of bleeding in these cases, and as with the hot techniques, the risk of bleeding is higher with the cold techniques. Next slide, please. And when we open the airways, the next thing is we need to keep it patent, and we have to think of stent, whether we can put a stent, which stent, and whether to put it or not to put it. There are various kinds of stent available in the market, but in the oncological setup, we end up using either a silicone stent or a covered metal stent more often than other. Next slide, please. And when we look at the stent, we try to find something which is ideally should be cheap, easy to place, easy to remove, with no or few complications, and suitable for most indications. And it should be adaptable as well, but unfortunately, one size doesn't fit all. Next slide, please. And all the various stent available have their pros and cons, and we can see that though silicone stents, which are human stents, are cheaper, but they are not very easy to place. They need general anesthetics as well as rigid bronchoscopy as compared to flexible bronchoscopy, which is commonly done in the bronchoscopy suite. And we can put a metal stent with a covered metal stent in these cases. The complications are very similar for both the cases, and when we look at what can be in what we hold in the future, we might be using different kind of stent which can be individualized by 3D printing for the individual airways, by drug-eluting stent, or even iridium particle studded stents. Next slide, please. This is not uncommon. We see patients coming through our emergency with massive pleural effusion, and this is another scenario where we sometimes we do not know the diagnosis, sometimes we do, and interventions as well as palliation both comes into play, and you have to do together sometime. What we can do for this kind of cases are whether we can do a therapeutic aspiration or put a chest in with a view of doing a pleurodesis afterwards, but sometimes we do not have a histological diagnosis. Next slide, please. In cases of recurrent pleural effusion, we can insert an indwelling pleural catheter where we can keep the patient out of the hospital, but technicality and availability and cost becomes an issue, and not many centers have the follow-up services for indwelling pleural catheter. The patient's treatment at home can be a challenge. You can train the district nurses or the family members or patient themselves to drain the pleural effusion, and that's the aim, to keep them out of hospital. When we do not have a diagnosis, or even sometimes when we do have a diagnosis, in case of massive pleural effusion, we can go by doing a thoracoscopy and putting a talc by Podras. And whether you can do a rigid thoracoscopy or a semi-rigid thoracoscopy, the results are pretty much similar. You can take the biopsy, which can provide you adequate sample for molecular analysis, and along with that, you can do the talc Podras, which is a much better outcome than talc slurry. Next slide, please. Now, we know that with the immunotherapy and more of targeted treatment, we are using more and more of these agents, and these do not come without any complication. They have their own downside, though fortunately the downsides are very limited as compared to the benefits offered by this treatment. In this case, it's a 66-year-old man with non-small cell cancer on pembrolizumab for PD-L1 positive tumor. Presentation is 3 weeks history of cough, fever, and malaise, shortness of breath, and hypoxia. And when we look at the X-rays and radiology, next slide, please, we can see a clear change in their lung parenchyma, and we can see that these patients do get side effects from immunotherapy by developing this pneumonitis. Next slide, please. And these are commonly used drugs nowadays, not only in lung cancer, but in other cancer as well. And fortunately, the incidence of side effects are pretty limited, in less than 10% in most of the cases. Next slide, please. And depending on the severity of the underlying problem, you can either delay the treatment, withhold the treatment, or sometimes you have to discontinue treatment. The important point comes with differentiating it from from underlying infection, particularly opportunistic infection. And we might or might not be able to do bronchoscopy because sometimes patients are too hypoxic to do a bronchoscopy. If they are on intubation, then it gets easier, but otherwise you have to rely on the sputum sample. And but important point is to make sure that there is no underlying infection. This needs treatment sometime with the stopping the or delaying the treatment with the immunotherapy and use of steroids along with it. If they do not improve, you might have to consider infliximab or MMF in these cases. Next slide, please. This is not uncommon. We do see hemoptysis coming through our clinics through emergency door, and one of the biggest challenges is whether to admit these patients or not, whether this is really hemoptysis or not, and whether it is coming from the upper airways, whether it is severe or not severe, whether it's massive or not massive. When we talk about massive hemoptysis, there's no clear definition to it. I think any patient who is at risk of compromising their airways or hemodynamic compromise, we call it massive. Next slide, please. You do a CT scan, CT angiogram, and look for any possible embolization of the bronchial arteries. Bronchoscopies, I would say flexible bronchoscopies. I think I'm not a big fan of flexible bronchoscopy in massive hemoptysis because the lumen of the bronchoscopic channel is very, very small, and you cannot remove all the blood. The vision is poor unless the patient is on ventilator. A rigid bronchoscopy gives a better lumen and control of the airways and might offer treatment of underlying tumor or bleed from it. And but whenever we see these kind of cases, we know that the prognosis is probably not good because there might be erosion of a major artery. Supportive treatment we always have to continue along with by transfusion, by tranexamic acid, and with or without use of opiates. Next slide, please. Sometimes we do come across this puzzling situation of use of moderate to severe cough, presentation of moderate to severe cough, and despite using antitussive and all the supportive treatment, this can be very, very difficult to control. We can use opiate, we can use pregabalin, gabapentin, and other medications, but sometimes you have to take a step back. You have to think whether change of underlying treatment of cancer itself might be needed in these cases. Next slide, please. Thank you. I'll stop it here. Thanks for. I'm happy to take any question here.
Thank you, sir, for a nice presentation. I think we're running out of time, so we have to move on to our next topic. Our next topic and the last topic for today is a panel discussion, and we all know that immunotherapy alone or in combination with chemotherapy has been a pivotal role in management of stage 4 lung cancer nowadays. And now we are more keen in doing NGS, and we end up seeing BRAF, MET, RET, and other rare mutation coming up positive. Although we've got data in the form of phase 2 trials and single center experience retrospective study, but there is hardly any phase 3 data on this rare mutation. So in absence of phase 3 data, whether immunotherapy alone or in combination with chemotherapy could be a standard option for even rare mutation positive patient, that is the question for stage 4 non-small cell lung cancer. So for this session, we've got our chairperson, sir, Dr. P.N. Mohapatra, sir. Sir is a senior medical oncologist and the director of Department of Medical Oncology, Apollo Cancer Center, Kolkata. Sir has more than 25 years of experience in the field of oncology and has been one of the lead medical oncologists in Eastern India. So I would request Dr. P.N. Mohapatra, sir, to introduce our moderator and the panelist And then I request Dr. Ashok to take over. Dr. P.N. Mohapatra, sir, over to you.
Thank you, Animesh. Actually, hello, can you
Yes,
hear
sir.
me?
Yes, sir, we can hear you.
Yeah, thank you. I think you discussed a little bit about the mutation part. Actually, if you see the mutation part, and the clinical trials, actually, the clinical trials actually are more of AGF or ALK or some ROS, but nobody has included or seen the patient of BRAF, RET, NTRK. But this mutation positive patients, except I think BRAF or KRAS, they don't do well with immunotherapy or immunotherapy chemotherapy combination. But sometimes what we see, we have the mutation, we don't have the drug, or if you have the mutation, the drug are costly. So I think we'll have an excellent moderation of this, and we'll start with the moderator. Moderator is Dr. Ashok, and he's from Kochi. Actually, he's a MD and MRCP, DM Medical Oncology, MRCP Medical Oncology, FRCP from Glasgow. He's a long qualified for this job, and he's actually practicing in Aster Medicity, Kochi. He's a faculty in actually MRCP examiner and faculty train those people who prepare the exam, and he's a program he do clinical trials. He's a co-investigator in clinical trials, and he
Some network issues with sir. Kashish, I think Dr. P.N. Mohapatra sir is having some network
Yes,
issues.
sir. He's having some network issues,
Yeah.
sir. So can I request you to introduce the moderator and the panelists, sir?
Yeah, I think that Dr. Mohapatra has already introduced the moderator. So, as a panelist, we've got Dr. Vivek Agarwala, medical oncologist from NH Hospital, Kolkata. Dr. Moses Arun Singh, one of my colleagues, and a clinical oncologist from Tata Medical Center, Kolkata. Dr. Bibhash Vishwas, medical oncologist from Tata Medical Center, Kolkata. Dr. Tanmoy Mukhopadhyay, clinical oncologist and my colleague in Apollo, Kolkata. Dr. Shudeep Das, medical oncologist from Medica Super Specialty Hospital, Kolkata, and Dr. Topesh Bhattacharya, consultant radiation oncologist from Tata Medical Center, Kolkata. May I request Dr. Ashok to take over?
Ashok, sir, please note,
Dr. Mohapatra is back.
Thank you very
Dr.
much.
Mohapatra is back. Sorry, sir. Dr. Mohapatra is back. Sorry, sir. I think you have got some network issue.
Internet problems. Yeah. Please,
Okay.
please carry on. Please carry on.
Okay.
Ashok, sir, also please note,
Yeah.
Dr. Sudeep had to leave because he had to go for another.
Right. Thank you very much for the organizers, Dr. Saha, for this wonderful opportunity for this moderating this session. Actually, I am standing in for a colleague of mine, Dr. Ajay Matthew, who's a consultant in the US. So I'll try to do justice to this talk. I also realize we're running a little behind time. So I'll make sure I'll be brief and not keep you from your dinners. Thank you very much for the very kind introduction, Dr. Mohapatra, and warm welcome to the panelists also. So first of all, when I got this question, so the topic that I had, it was to be summed up in one word. It's a challenging topic because everywhere we go in oncology, the buzzword is about immuno-oncology and immunotherapy. So this is my topic. That's immunotherapy alone or in combination with chemotherapy should be the standard of care, even in rare mutation positives. That goes to say that it should be the standard of care in the more common mutations as well, stage 4 non-small cell lung cancer. So I'll just go through a bit of the basics. We all know that 20 years back, life was much more easier. We just had stage 4 lung cancer and other lung cancer. Then we had non-small cell and small cell. Then we had the histological subtypes, and then we had a whole host of markers, molecular markers that came into being. So now we know so much about lung cancer that the battle against lung cancer has turned from a hopeless battle with meager weapons to a problem of plenty. So we have so many things that we can use that we are really not sure how to go about it, or in what sequence to go about. So we'll concentrate on lung adenocarcinomas for now, even though the topic was NSCLC as a whole. So we all know that these are the divisions in the driver mutations. And we also know that EGFR is the one that we see most commonly. In the Indian population, this is the Western data, that's around 15%, 12 to 15%. In India, it can vary as much as 15 to 50%. And it's even higher in certain other Southeast Asian countries. And these are the other mutations that are possible. This is something that we all know. So we have now so many targets. To target or not to target in India is rather the question. So we have all three generations of EGFR inhibitors. We don't have the molecules for EGFR exon 20, but it is available in the West. ALK, we have all the three generations. ROS, we have most of the drugs. Entrectinib, of course, is not available. We do not have the drug that targets KRAS, but it is available on a compassionate basis. If you can just note this, it's basically the green ones are the ones we have. The yellow ones are the ones we can get through a compassionate basis. The red ones are the ones we have no way of getting. And the blue ones are the ones that are not approved. So as you can see, there's a lot of green. So we have targets for almost all these. The most recent target was capmatinib for MET inhibition. I'll be speaking about that briefly. And we have a whole host of other drugs. One thing of interest is that although MET inhibition has been a very important mechanism that has been looked into, only one trial is actually actively looking into MET inhibition in lung cancer, that is for selumetinib. It's still under trial, but the preliminary data shows that there is some PFS benefit. So I'll just go to the next slide. So this is the overview. 60% of all non-small cell lung cancer will have one target or the other. And immunotherapy will work in a majority of these patients, either alone or in combination with chemotherapy, as long as the PD-L1 is more than 1%. And if you're going to give it as a single agent, you can, if the PD-L1 is more than 50%, we have pembrolizumab approved as a single agent. And in combination, if the PD-L1 is between 1 to 50%. Why add chemotherapy to immunotherapy? The theory is that it enhances the recognition and elimination of tumor cells by the host immune system. It reduces the immunosuppressive tumor microenvironment as well. So I'll just go directly to the case. We have a 60-year-old female. She's a non-smoker. She has no comorbidities. She has chronic cough, dyspnea, 2 episodes of hemoptysis. This was in November 2019. A chest X-ray showed a left lobe, lower lobe mass, bilateral pleural effusion. A PET CT was done that was showing a left lower lobe primary, bilateral lung nodules, and a left adrenal metastasis. A lung biopsy showed a grade 2 adenocarcinoma, CK7 positive, TTF1 positive, NAPSIN-A positive, CK20 negative. And so this is a very, very generic, very common scenario that we see in our lung cancer patients. So what are you going to do as further tests? I think I'll start from Dr. Vivek, one of the only panelists I know personally. So Dr. Vivek, if you're there, can you take this?
Yeah, hi Ashok.
Hi, how are you?
Yeah, hi, can you hear me?
Yes, I can. Go ahead, please.
Yeah. So, what I would prefer in any of my metastatic lung cancer patient is to send an NGS for a broad, targetable panel, which includes at least, EGFR, ALK, ROS, MET, BRAF, and RET, and all those targetable that you've already mentioned with PD-L1. And suppose if there are patients who are unable to go ahead with NGS because of economic constraints, then I make sure at least I do an EGFR by PCR and ALK ROS by IHC and a PD-L1 by IHC also.
Right. That's perfectly summed up. Dr. Moses, Dr. Biswas, Dr. Tanmay, can I have your opinions?
I'll also go for
NGS with PD-L1.
Right.
NGS we have already mentioned the most common one targetable,
Yes.
including NTR.
Right. Dr. Moses, Dr. Stanmai, I think everybody is on board with this. We'll go for option 4, the full NGS panel.
Yeah, if the patient does not have any financial constraint.
Yes, we are going to assume that the patient has no financial constraints through the entirety of the discussion for academic purpose at least. So yes, so the patient, now this is something called the CAP IACLC guidelines. This was last updated in 2018. So in that they clearly mentioned that the most important first line test to be done is EGFR, ALK, ROS1, BRAF and PD-L1. They have suggested that we keep RET, HER2, KRAS, MET as a second line part of a larger testing panel. However, when you look at the latest NCCN guidelines, you can see that they clearly mention that all these have to be done. And they have specifically mentioned MET in the MET skipping mutation in exon 14, which I'll come to in a minute. So we are all on board with this. So for this patient, we sent a 12 gene NGS panel, including PD-L1. The patient had EGFR positive, L858R. All the others were negative, and she had a PD-L1 of 55%. So how will you treat? I think, can Dr. Moses take this question, please?
Yes, so did you mention the patient had EGFR positive?
Yes, sir. The EGFR L858R is positive, PD-L1 is 55%.
Yeah, I think I prefer osimertinib as the first choice.
Right.
Because you said that the patient is able to afford all drugs if possible.
Right.
I would prefer osimertinib as the first choice.
Right. Any other difference of opinion among the panel? Is there anyone who would like to try immunotherapy for this patient? Or perhaps a combination of immunotherapy with EGFR mutation?
No,
EGFR
only
mutation.
TKI.
Only TKI, yes, right. So I'd like to just give a small study about this. It's a very small trial. There were only a very small number of patients, only 25 patients. Basically, they were trying to see if there was any efficacy when you gave PD-L1 with an EGFR inhibitor. So in this, there was a very high percentage of patients who had very high PD-L1 expression. 73% of patients had PD-L1 of more than 50%. And the trial was discontinued because of lack of efficacy, and only one patient had a objective response, and even that found that the original report of that patient being EGFR mutation positive was erroneous. So it was concluded that immunotherapy has a lack of efficacy in TKI naive PD-L1 positive EGFR mutant patients with advanced NSCLC, even if the PD-L1 expression is more than 50%. So it's so they concluded that it's not an appropriate therapeutic choice in this setting. So for some reason, this patient was started on erlotinib, probably because of the availability issues back in 2019. Anyway, she was given erlotinib. She was started on erlotinib, and she had a disease-free interval of 16 months, whereas at which time she progressed with documented new liver lesions and increase in lung lesions. So the next question, if Dr. Tanmay can take it, would you want a repeat biopsy?
This patient initially had 858 mutation positive, wasn't it?
Yes.
Yeah. So in that case, well, I possibly won't record any repeat biopsy, but I'll switch that patient to the different TKI.
You will be going to osimertinib directly.
Yes.
Right. Dr. Biswas, Dr. Vivek?
Yeah. So I'll go for a cell-free DNA first. If negative for any mutation, then I'll go for a biopsy. That will be my approach.
Dr. Vivek?
I think I agree with what Dr. Pivash has said. Cell-free liquid biopsy is good. It's a very good strategy to reassess the resistance mechanisms, and probably it is more reflective of the resistance mechanism overall, because it tells you whatever be the mutations be present in any sites of metastasis, it can reflect that as against local biopsy. So I'm happy to do a liquid biopsy and choose the next line of treatment accordingly.
Okay, I have a question here, a personal question. Suppose the patient has a lesion that is easily biopsiable and the patient is willing for many times we see that the patient is not willing for a rebiopsy, or the lesion that has to be biopsied is difficult to biopsy, or there is some technical issue. So at that time, of course, we all go for liquid biopsy. But suppose we do have a proper biopsy site that is easily biopsiable, would you still prefer to go for liquid biopsy?
No, you can do a biopsy.
So I got your question, Ashok.
Right.
Yeah,
so actually
Ashok,
that was my next question.
Yeah, so Ashok, if it is an easily biopsiable site, and that is the site of progression, then I'm happy to do, if the patient is willing, I'm happy to do biopsy from that site. However, if if there are multiple sites at which the disease has progressed, then when you re-biopsy, I want to biopsy from the site where the disease has progressed, rather than repeating a biopsy from the primary site. Because you want to know the resistance mechanism. And liquid biopsy, it not only just has the advantage of the ease also, but it gives you a sum total of what are the how the resistance mutation is behaving at all sites. So it is reflective of the entire disease burden and instead of a single site. And we all know that there is tumor heterogeneity especially in driver mutation positive cancers.
Right. So another point I'd like to make is just a couple of years back, liquid biopsies were not that preferred because it was thought that the concordance was not very good. But then liquid biopsies also, like every other technology, has advanced. And now we are seeing concordance of in excess of 90%. So it's absolutely fine to go with liquid biopsy if there's no other choice. And of course, even in ease of treating patients. For example, in my set of hepatocellular carcinomas, I don't even bother because I don't start them on treatment with a biopsy to begin with. So liquid biopsy is the norm for them. I don't even think of a biopsy, of a tissue biopsy. So anyway, I think we are on board. Everybody's on board with this. Just an extra question: do you think the PDL1 should be repeated?
No.
No, right. I think that is the consensus of the panel. So going to the next question. So the repeat biopsy showed a grade 2 adenocarcinoma. The EGFR mutation was the same. It was showing an L85R. There was no T790M. There was no rare mutation. There was no clear mechanism explaining progression or resistance. So just a slide about the mechanisms of resistance. As you can see, there's so many mechanisms. They have divided it into three. That's one is the EGFR dependent mechanisms. The second is the bypass signal activation. And the third is the histological transformation. As we all know, is the most difficult to treat. And we know that half of our patients who progress on a TKI are going to have a T790M mutation. And we have a very effective drug for that. And we can give that for those patients. But in this patient, she does not have a T790M mutation. So what would you prefer in the next line? Dr. Moses, if you can take that.
Yeah, so in this setting, I would usually start them on cytotoxic chemotherapy. Right,
cytotoxic chemotherapy. Would you want to add anything like bevacizumab or immunotherapy at this point?
Yeah, I know there is this quadruple therapy available for this patient, but I don't usually use that. I usually prefer using chemotherapy alone for this patient.
Alone, right. Is there any difference of opinion in the panel? Dr. Biswas, Dr. Vivek, Dr.
So I also do give chemotherapy. I have started my first patient on ABCT, just like we do. I don't have much experience, but yes, in a fit patient with a wide burden of disease, I like to give a trial of ABCT, but at the end of the day, 90%, 95% land up in only cytotoxic.
Right. That's true, because the cost factor involved of adding the quadruple drug regimen. So if you just go to the next slide, this is what the NCCN guidelines say. You have progression on erlotinib, afatinib or gefitinib or whatever. You do T790M, and you have multiple metastasis, not limited metastasis, multiple lesions, and T790M comes negative, then the preference is to go for systemic therapy. So these are the drugs, and as you can see, the category 1 recommendation is for the ABCP regimen. So we'll just talk about that briefly. That came out in the Empower 150 trial. It was stage 4 recurrent metastatic non-squamous NSCLC, chemotherapy naive. They had taken any PD-L1 IHC status. They had randomized it to atezo, paclicarbo, atezo, paclicarbo, bev, and paclicarbo and bev. There was no crossover permitted in the maintenance therapy, and it was treated with atezo till progressive disease, or treated with bevacizumab for those patients who didn't get atezo. This is something that we all know. We have all seen this graph. There's a nice, beautiful separation of the graph that shows that ABCP had a very significant progression-free survival of 36%. That's double that of just paclicarbo-bev at 18%. And it was seen that it was beneficial in all the subgroups. Right. So this is the rate of overall survival. Again, it was significant, and the p-value is only 0.0. The p-value is 0.02, and as you can see here, the at 2 years, ABCP gave a rate of overall survival of 43% in these patients, and BCP was giving 33.7%. So then they took the subset of patients in EGFR and ALK positive, and they compared arm B versus arm C. If you remember, arm B is the one with the quadruple regimen. Arm C is the one with the paclicarbo-bev. So here you can see there's a very significant separation of the curves. The hazard ratio is 0.4, and arm C was giving an overall survival of 17.5 months at 1.5 years at the time of data collection. So this became one of the standards of care. EGFR ALK positive patients who had progressed on first-line TKI without a targetable resistance mutation, the best second-line option appears to be ABCP regimen. The final OS data was published very recently in November in the Journal of Thoracic Oncology, and they had concluded that based on this, the ABCP regimen was approved in the United States for these patients. But in patients who have progressed with EGFR ALK, it's not approved in the US, but it is approved in Europe and Japan. So this is a slide I had already mentioned. So what we see here is that we have an answer, we have a very easy answer for patients who have T790M mutation, that is osimertinib. What about the patients, the other half of our patients? What do we do? It's again a straightforward question. When you have histological transformation, like if it's going to be a small cell carcinoma, we can always shift to chemotherapy that targets small cell carcinoma. I'm just going to go briefly through all these other mutation, the mechanisms of resistance in EGFR mutants. So you take patients with HER2 mutations. There are 3 types. One is the gene amplification, one is the overexpression, and one is the point mutation. Gene amplification is very rare, de novo, but it's very high. It's as high as 13% as an EGFR resistance mechanism. And very surprisingly, none of the first-line agents for HER2, anti-HER2 or HER2 inhibition showed any benefit. Trastuzumab and pertuzumab failed. We have a small phase 2 trial of 18 patients, which showed that TDM1 showed an overall response rate of 44% with median PFS of 5 months. This is a subset of lung cancer that is that has very poor survival, and this drug has been now approved by the FDA for use in patients with HER2 mutations in EGFR positive, in HER2 positive NSCLC. There is a huge list of TKIs: lapatinib, afatinib, dacomitinib, neratinib, quizartinib, pyrotinib, taxol. Everything has been tried in EGFR positive mutations. Basically, the reason is afatinib and lapatinib have a dual HER2 inhibition, EGFR and HER2 inhibition. The others are irreversible pan-ERBB receptor inhibitors, which means they act against HER1 through HER4. So the only one that has been found to have significant benefit is poziotinib. We have used one for one patient, poziotinib. We have achieved a partial response to that patient. It has been found to be 6 times more potent in anti-tumor activity in patients with HER2 exon 20 mutations, very specifically HER2 exon 20 mutations, as compared to both afatinib and dacobitinib. So there was a trial for that showed 50% of patients with this HER2 exon 20 mutation had a radiologically confirmed objective partial response. So only poziotinib and to a certain extent pyrotinib has shown promising responses, particularly in HER2 exon 20 insertions. And and as far as poziotinib is concerned, I know for a fact that it can be obtained through the compassionate basis program. What about the role of immunotherapy? There have been only very small case series and a small number of trials, mostly from China. The responses has been poor. Like Dr. Mahapatra sir had mentioned, other than very few select cases, when you have a targetable driver mutation, it seems that immunotherapy doesn't really work very well. So there are 2 trials I put up here. You see that overall response rate is as low as 7% in one. And the other one, the overall response rate was found to be 27%, but as you can see, the PFS is so low, it is only 2.2 months. So it doesn't seem to have much role. What about MET inhibition? Now, MET isn't, there are basically 2 major mechanisms. One is MET exon 14 skipping mutation and the MET amplification. So again, it was found to have very poor responses to immuno-oncology. We have a lot of MET inhibitors actually. There was a time in which we had only crizotinib. Now we have capmatinib also. The latter is a very potent MET inhibitor, as you can see in the IC50 table that I've given. The trial that was done was a geometry trial. That was a phase 2 trial. It came out in 2020 in NEJM. It showed that there was an overall response rate of up to 67% in treatment-naive MET exon 14 skipping mutations and 41% in pre-treated cohort. The PFS was as high as 12.4 months. Now, before I say anything further, I'd like to make the point that for immunotherapy in MET mutation, the response rate was as low as 1.9 months. Sorry, the PFS was as low as 1.9 months, and the overall response rate is only 17%, as compared to what you see here of response rates of 67% and then 41% even in the pre-treated cohort. So again, here these are the trials. That the first trial is the one I was talking about. The overall response rate was only 17% in that trial. Only in one trial, but with very small numbers, only 13 patients, they showed an overall response rate of respectable overall response rate of more than 40%. But everything else, overall response rate is very low. PFS is very low. So immuno-oncology does not work in MET either. What about KRAS? This is a whole list.
Ashok, can I just interrupt?
Sure.
Can we ask our panelists about their thoughts? Say, for example, we've got a patient with MET exon 14 skipping mutation and PD-L1 90%. Can you ask our panelists what are their thoughts about using chemoimmuno or immunotherapy instead of MET targeted therapy? And we've got Dr. Topesh Bhattacharya also in our panel. Can you ask our panelists about the
sure, sir.
What they thought about
Dr. Bhattacharya, if you can please comment on that question.
So as Dr. Animesh is mentioning about, it's a MET exon 14 skip mutation positive and PD-L1 is around 90% or so. So definitely if it is a MET X4 skip mutation is positive, we know that mostly we found in the sarcomatoid carcinomas and all. And if it is positive, then I will definitely try for the targeted agent, like if the patient can afford or if he gets through compassionate scheme, like I will go for the capmatinib. And we know that regarding the results of immunotherapy in MET positive, there are many conflicting results. So it's not very clear or not very evident. So definitely I will go for the targeted agent, capmatinib, if patient can afford or compassionate access.
Do the other panelists have any difference of opinion? The hypothetical question here is you have a patient with MET mutation with a high PD-L1 ratio. Would you prefer to do anything differently?
No. So all the targetable mutation with the driver mutation, irrespective of PD-L1, the choice remain either that particular targetable TKI is available or accessible by any means, or simple chemotherapy. No role of IO, not at least in the first line or second line, maybe in the last line. I think that.
Right. I think that Dr. Shah, I think that answers the question. If you go through the trial, the largest of these trials, that is the one by Shabri et al., there were patients with reasonably high PD-L1 expression, but they didn't have much of a response. And this has been seen more or less for not only MET mutation, it has been seen in, like I said, in in one of my slides, I had mentioned about EGFR in MET mutation, and like Mahapatra sir said in the beginning, even in RAS mutation, they have been found to be not of much benefit. So these are the trials for RAS. Again, not small trials. The first one had an participation of 271 patients. The overall response rate is only 26%, and PFS anything ranging from 2 to 3 months was what was available in the patients who were given immunotherapy in KRAS mutation. When you compare it to the drug you have for KRAS, we don't have the drug yet. The drug is called sotorasib. The trial was called Fortbreak 100, and it has been approved also in KRAS mutant NSCLC. The overall response rate was 36%, but the median duration of response was as high as 10 months, which is much higher than most of the immunotherapy that had been tested in this setting. So we have alternatives, and like Bhattacharya sir said, now we have multiple lines we can plan. We can give a KRAS inhibitor in the beginning if we get it through a compassionate basis, and after that, perhaps if that patient has a high enough PD-L1, we may be able to offer immunotherapy along with or without chemotherapy in third line or more than that. BRAF mutation, same thing again. We have effective agents.
Only about KRAS, sorry to interrupt. Only about KRAS, what I would say, the KRAS mutations all are not same. G12C,
yeah,
they do show response to the immunotherapy, but you have co-mutation like STK11 or TP53, they don't show much response to the immunotherapy.
Yes.
So I think the response rate what you are showing may not reflect that, because it may be they have not tested all different co-mutations within the KRAS.
That's true, sir. And even the drug that is approved is only for the G12C mutation.
Yeah, and
sotorasib is only for G12C. So coming to BRAF, I think more or less the same picture, but it does do a little better in BRAF mutants. You see overall response rates in the 30s. PFS is around 3 to 4 months. The trial, but when you compare it with the drug that we have, the targets that we have, there was a BRF trial that was a multi-cohort trial. It was again a phase 2 trial in BRAF mutated NSCLC. The overall response rate was as high as 63%. The median PFS was with chemo in these patients. As we know, in any tumor, when you have BRAF, they're not going to respond very well, even to chemo. So the PFS with chemo alone for BRAF mutant NSCLC was as low as only 4 months. If you added dabrafenib alone, that PFS could increase to 5.5 months. And the combination of dabrafenib and trametinib increased the PFS, actually doubled the PFS to 10 months. So again, when you look at the slide, there's no trial that shows anything approaching 10 months for immuno-oncology. ALK, the same, more or less the same story. Again, numbers is the problem. We don't have numbers. We don't have data to support any of this. As you can see, 0 overall response rate. And in a very small trial with 7 patients, there was an overall response rate of 28.6%. RET mutation is another one. Again, we have an effective drug for it, selpercatinib. There was a trial called Libretto 001 trial, again published 2 years back in NEJM. In pre-treated patients, overall response rate was 64%, and 81% of the responding patients had a longer duration of response, as up to 6 months or longer. And the table below that gives the ICI trials in RET mutant patients. Again, the small number trials show overall response rate of 37%, but that just means that in 9 patients, 3 patients responded and had a PFS of 7.6%. So again, we lack data, so we don't know really if immunotherapy will work in RET mutants, but we do know that we have a good drug that works in RET mutant NSCLC. So coming to the question that I was told to moderate in this, so should immunotherapy alone or in combination with chemotherapy be the standard of care in any stage 4 non-small cell lung cancer with a targetable oncogenic driver? So a yes or no from the panel would be appreciated.
Simple no.
No.
Right. So I think the answer is no. I just put an asterisk because I think with the possible exception of EGFR mutant NSCLC patients progressing on TKIs and without T790M resistance mechanism or a targetable resistance mechanism, ABCP regimen is a reasonable option, is what I feel. I just put this up because this is what NSCLC looked when I was studying in MBBS. It was just a long road to the graveyard. Now this is what the road to treatment of NSCLC looks like. But the problem is we have so many choices that we end up like this. That brings me to the end of the session. If there's anything else we could discuss, we can take it up right now.
Only thing is, what I have question, not the question, but just to get everyone's opinion, because you said the BRAF mutation, possibly the common one you mentioned, V600, where you have the debrifev. But if it is a non-V600, then in those situations, would you consider for immunotherapy as a first line, because they do respond well to the immunotherapy?
Sir, certainly, because BRAF is actually, when I look through all the data, BRAF is the only one mutant, a targetable mutation, which had something close to reasonable responses to immunotherapy.
Yes.
The problem is we don't know how well they respond to the non-V600 mutations. As far as the targets itself are concerned, we're not sure of that. The data is very limited. And it is even more limited when it comes to immunotherapy. However, if a patient does come, I think we are all quite ready to try it, especially if the patient has a high PD-L1, or if there's I would be actually more comfortable if there's an extra biomarker like a high tumor mutation burden. So then, yes, definitely, I think we could try. I would like the panel to also comment on that.
On top of that, I want to add one thing. If it is BRAF V600E and say TMB is high or PD-L1 is high, and if the patient is smoker, then also they respond well.
Probably, yes.
Yeah, but in that situation, you have the targeted treatment, so you try first that one. But if it's a non-V600, then the issue is whether the patient, if the PD-L1 is high, then whether you try immunotherapy, maybe along with combination with chemotherapy.
There's another reason also, because dabrafenib trametinib is not that easy to administer also. The patient himself will say, I don't want this, I'll take immunotherapy. And it's not a big difference in cost also.
Yeah.
Dr. Ashok, I'll make a comment. So we all know that when EGFR TKI or the ALK TKI or the Roche TKI came into market and came to approval, they're all gone through randomized controlled trials. And they have all been compared with standard of care, which was chemotherapy that time. But now when you're talking about this rare mutation, MET, so RET and other KRAS and all this, so I understand that it's very difficult to conduct a randomized controlled trial. But in absence of this phase 3 data, I think there are data that suggest that this mutation positive patient might not work well with the immunotherapy. But in absence of this phase 3 data, how comfortable we are using the rare mutation positive targeted therapy. And till I think couple of years ago also in NHS, they didn't use to test all this patient with all this NGS marker that you're doing. So EGFR, ALK, ROS1 and PD-L1, all that they're doing. But the question is, in absence of randomized controlled trial or phase 3 data, how comfortable we are to use this targeted agent in patients?
Sir, I think you mean to ask, in absence of data, how comfortable are we to use immunotherapy?
No. The rare mutation positive targeted therapy.
Sir, most of the sir.
So my point is, when EGFR TKI, ALK TKI, or ROS TKI came into market, got into the approval phase, they all have gone through phase 3 data, isn't it?
Yeah.
All been compared with standard of care, which was chemotherapy. And for this rare mutation, which has MET, BRAF, or RET and KRAS, we don't have any phase 3 data, isn't it?
That's true. Mostly it's phase 2.
Yeah, phase 2. So in absence of this phase 3 data, how comfortable we are using this in clinical practice?
Sir, personally speaking, I feel that there has been a paradigm shift in the way we see data, because there was a time in which you didn't touch something without phase 3 data. Now we see that even the FDA is approving drugs with small phase 2 trials, like trials with like 50 patients, things like that. We do like the trials that we use for like pilot studies for our thesis and all. And because at that point of time, we are really out of options. So I feel that as long as the drug is approved and there is a reasonable data, I'm not going to classify it into phase 2 or phase 3. If there's a reasonable phase 2 data to support it, then definitely I think I'd be comfortable using.
Maybe any comment from other panelists regarding this?
Well, question is, you are questioning that the patient, the tissue has driver mutations, but you have an agent, but you are questioning that because you do not have phase 3 data, then you won't use it. So in that
is the question. I'm asking for comments from panelists.
No, in that situation, what we would use it? Because chemotherapy is a better option, or because we won't possibly use the immunotherapy. So chemotherapy is better option. So possibly we need to extrapolate until we get the phase 3 data that the driver mutation is there, the molecule is there, and phase 2 data is there. And based on then, I think we should be comfortable using that medicine.
Any other comments from any other panelist? Vivas sir, Moses, Dr. Kapish.
I think Vivas sir has left, and I mean, even though they are all single arm studies, the response rates that we are seeing in all these things and the PFS data that we are getting compared to all the data that was just shown for all these patients in terms of immune checkpoint inhibitors, I think that is very much convincing to opt for targeted therapy in this setting than go with immunotherapy.
So in those cases, endpoint is also important. That's my thing, that how much benefit you are getting in terms of PFS or response rate or whatever. So that in those trials, what kind of endpoint you are looking for, that is also important, whether you are going to use that drug or not.
Thank you very much. Thank you very much, panelists. Thank you very much, Dr. Ashok, for your moderation. I think Dr. Mohapatra has also left. So we have to conclude our session. I'll hand over to Dr. Pradeep Mondal for concluding remarks and word of thanks. Dr. Mondal, over to you.
Thank you. Yeah, I'm audible.
Yes, you're audible.
Yeah. So thank you, Onimes, my dear friend, and organizing secretary for this beautiful evening seminar we have organized. So that lung cancer is always a controversial topic. So in recent, that lots of armamentarium or treatment is available with advanced, locally advanced or early lung cancer. So mostly that we have improved our survival day by day in lung cancer with all these therapies, targeted immunotherapy. But there are always some controversies will stay, and we have discussed few of these controversies through that lectures and beautifully designed debates. So I'd like to thank my dear friend Dr. Onimes the clinical oncologist from Apollo Hospital, for organizing this beautiful webinar. And I would like to thank Webinar Creations Cassis for beautifully organizing this seminar. And at the outset, I will like to thank all the speakers, moderator, chairperson, the senior oncologist like T. Raja sir, P.N. Mahapatra sir, that Raja Dhar sir, and all the speakers, moderators, panelists, and all the attendees who have attended this seminar. So basically that we have learned a lot and we have discussed a lot. It's an extensive discussion, beautifully moderated panel discussions, and all the debates were very informative. So I will like
Pradeep sir, Animesh sir, Pradeep sir has just logged out. I think he's facing network issues.
Can I ask Kashish, can you give some from your end, vote of thanks and concluding remarks? I think you have done an excellent job doing and organizing this CME, and without your support, it would not have been possible to organize it so beautifully. And I thank my PGTs also, who are in the background, are also helping me with this webinar, and they have been helpful throughout. So Kashish, your vote of thanks and concluding remarks. I think hats off to you for organizing this.
Thank you so much, sir. Thank you so much, sir, for the opportunity. Once again, on behalf of our organizers, I would like to thank our supporters, Indian Cooperative Oncology Network, and of course, the Indian Chess Society. But without that, without the support of them, and also with our sponsors, Dr. Reddy's, Roche, and Cipla, we thank everyone for supporting this webinar. Once again, a special thank to our faculty members and our delegates for delivering wonderful lectures and a wonderful panel discussion. With that, we come to an end of the session, and we hope to see you soon for our next session. Thank you, everyone, and good night, and wish everyone a great week.
Thank you, everyone. Thank you. Good night. Good night.